Hello, hello, hello. आवाज ओके है का? Thank you very much, Munde sir, our speakers and all officers. Doctors say only a doctor is blessed with the magical powers to treat a life, to bring health into our lives, and to be there with us when we have lost all the hopes. Yes, means we one of the most inspiring figures of the society, and their effort should be celebrated not today but every day. In terms of respect, in terms of faith, and yes, in terms of responsibility and humanity. During this pandemic, we doctors, yes, we brave medical army stand strong with the thermometers, with the stethoscope, with our own hospitals, and what not as our weapon. And too many sacrifices, yes, definitely with no regrets at all. So really, I salute all the medical fraternity and feel proud myself as a doctor. So this year is really a very special to appreciate all the doctors who deserve their day, and that is called as a real doctor day. For this, we are very much fortunate to have with us our chief guest, our own family, GPA family member, Dr. Sudhir Kumar Munde sir, as a chief guest, and Dr. Geeta Bora as a guest of honor. I welcome you, sir. The day will start with our academic session, which is followed by the Doctor's Day celebration. In this program, we felicitate one of our family physician by the GP of the Year award. And also there is a felicitation of our children for their special achievements. This year, we will felicitating our real heroes, that is real Corona warriors, who works very hard and run their COVID hospitals. So dear friends, be ready to enjoy our special day with our GPF family. Now I invite our GPA President, Dr. Shivaji Kolle, to say a few words on Doctor's Day. Over to you, Dr. Kolle, sir.
नमस्कार मित्रांनो, डॉक्टर डेच्या या प्रोग्रामच्या निमित्ताने प्रथमतः सर्व जीपीएस सभासद आणि यांचं स्वागत करतो. खरं तर हा दिवस आपण 1 जुलैला सेलिब्रेट करत असतो. आपल्या रुटीन ऍडजस्ट करून सगळं करणार असतो, त्यामुळे आपण आज हा डॉक्टर डे साजरा करतो. या निमित्त मुंडे सर, डॉक्टर गीता बोरा या चीफ गेस्ट आहेत, यांचंही मी स्वागत करतो. आजचा कार्यक्रम लवकरात लवकर सुरू होऊन वेळेत संपवावा अशी माझी इच्छा असते. त्याच्यामुळे कुठलेही काम करताना आपण गणेश वंदना करतो, गणेशाची प्रार्थना करतो, गणेशाला नमस्कार करून यांचा कार्यक्रम सुरू करण्यासाठी विनंती करतो. थँक्यू.
Thank you, Kolle, sir. So with this positivity, we'll just proceed with our today's academic session. Our first speaker is Dr. Vishnu Hegde, sir. I welcome you, sir. Sir will guide us on third wave children precautions and possibilities. To chair this session, I invite the chairperson, Dr. Naz Parveen Inamdar, and Dr. Minal Pawar on the dais. Dr. Naz Inamdar, she is a BMS, she is a general practitioner and practicing at Bhavani Pet since 25 years, and she is our General Practitioner Association life member. Our second chairperson is Dr. Minal Pawar. She is MBBS, worked as a medical officer in BMC for last 10 years. She was a family physician in Pune since more than 10 years, and she was a treasurer of Kothur Doctors Association. Over to you, Dr. Nazim Andar.
Good morning, everyone. Our first speaker, Dr. Vishnu Hegde. I would like to, sir, speak up on the stage. His topic, third wave, children precaution possibilities and challenges. Qualification. Dr. Hegde has MBBS and DCH. Topic of special interest, nutrition and gastroenterology. Sir has done research in 1987 from BJ Medical College, Pune. He has worked at Sassoon Hospital, Rubihar Clinic and KM Hospital. He has worked as a research officer at KM Hospital, Pune for 4 years. He has experience in research and nutrition of low birth weight babies. Achievements. Dr. Vishnu Hegde has won gold medal for research presentation on nutrition of low birth weight babies. He has over 20 years experience as a pediatric consultant. He is a life member of Indian Academy of Pediatrics and National Neonatology Forum. He has published paper in national journals on pediatric liver disease and nutrition. Please carry on, sir.
Good morning, everybody. On behalf of Doctors Day, I greet you very heartily, and I'm going to speak on third wave and children, precautions, possibilities, and challenges. I deliberately use the word uh, third wave and children because I not use the word third wave in children because that would give an impression that it is exclusively present in children, which is not the case. Next slide. How does this coronavirus spread? The coronavirus, which is a spherical virus, spreads by coughing, sneezing, and talking via the droplet infection through the breath, cough, or it spreads from one contact to the susceptible person. And there is uh, the preventive strategy for this is to use a mask and a social distance and maintain a social distance. Next. Now, this fomite is also one of the mode of transmission, but it has been not considered to be that important for the reason that initially it was thought that the coronavirus that number of hours, but this is not the case. It was found that that was done in for laboratory case in the laboratory in which perfect conditions were there for the virus to thrive. But in real world, the formats are not a very important mode of spread, but it's still a mode of spread, and therefore hand sanitization is also equally important. Next slide. So let us briefly go into the history of the pandemic. So this is an influenza pandemic which was there in 1918, and it was one of the biggest pandemics, or rather the biggest pandemic that we have had so far in terms of mortality. Next slide. It was around 5 crore deaths. If these 5 crore deaths were more than the number of persons who died in the First World War and the Second World War combined. Young people were affected between the 20 40 years of age, and also the children were affected, but they were affected for a lesser duration, for in a lesser intensity, and also the elderly people were less affected. Next slide. Nothing was known about this epidemic till decades of research later on showed that it was because of an unusual and hyperimmune response which contributed to the lung damage. Next. Now, having learned this, we come to the present corona pandemic. So this present corona pandemic has totally shut down the world. It has brought the world down on its knees. Next. The features of this is that the children are less affected, but elderly people are more affected. And the persons with comorbidities are affected because of very obvious reasons. And this is the most peculiar part of the corona pandemic. There is a very rapid appearance of occurrence. Next. Next. The cytokine storm and the immune dysregulation is an important step in the pathogenesis. I mean, any corona infection, the pathogenesis depends on the first week of viremia, and then there is the first cytokine storm, and then you go to the ARDS stage. So cytokine storm is a very important part, and we have to control the infection here so that it doesn't proceed to the ARDS stage and then ICU stage. The disproportionate immune response, which is responsible for most death, and the most death occurs in the second week of life. Next. The children are less affected. And here is a child is giving a double thumbs up so that because of that. Why are children less affected? First, there are 4 reasons for this. First is that the lower exposure, as they are homebound, there are no school, and they are at home. So therefore, there is a lower exposure to the virus itself. Next is viral co-infections. Viral co-infections like influenza, parainfluenza, respiratory syncytial viruses. These are what are important, and these can compete with the coronavirus and for the attention of the ACE receptors, and if it is that present in the respiratory tract, they do not allow the coronavirus to be. Another important reason why the children are less affected is because of the ACE receptors. These ACE receptors, ACE2 receptors, are expressed in the lungs, and it is also expressed in the intestines. Now it is expressed to a far lesser quantity and are far less functional in children than in adults. And this coronavirus spikes attach to the corona ACE receptors and then enter the pneumocytes of the lung and destroy the cells. And this is the way the disease proceeds. Now what happens is that these ACE2 receptors are less in number, so therefore the coronavirus can't enter the pneumocytes. Next is the reason why there is a lesser immunity is that the immune response in a children is not inflammatory or not inflammogenic as in an adult. Next slide. So what are the experience that we gain from the first and the second wave? The first experience is that the children are less affected for the reasons which I have just mentioned. And the second is that vaccine helps in reducing the severity of infection, but whatever the infection was there is decreased by the vaccines. And the patients who are admitted in ICU, it was found that in the second wave, most of them were not vaccinated fully, and therefore it can be an important lead for that. Now we shall go to the COVID-19 management in a child from 1 month to 19 years old, and this is a statement by the Indian Academy of Pediatrics. It is the latest statement in April 2021. Now, when do we suspect COVID? The usual symptoms: fever, headache, myalgia, fatigue, tiredness, coryza, cough, sore throat, etc. Also diarrhea, vomiting, and abdominal pain. In an infant, there can be poor feeding, loss of taste in a child more than 8 years of age, or if there is a rash, conjunctival congestion, shock, or if the child is asymptomatic but has a close household contact with a COVID-19 case. Many patients are there like this, they're asymptomatic, but they have a close household contact. Now, which test should we do? There are 2 types of tests, the rapid antigen test and the RT-PCR test, with both its advantages and disadvantages. The advantage of a rapid antigen test is that it is cheaper and it can be, the report is available in a few hours. But the disadvantages is that there is a lot of false negative reports. In the RT-PCR has got it's a gold standard for the diagnosis, and you can see that it comes very few false negatives are there, but it comes after a few hours and it is more costlier. Now, which test to do? If the patient is having asymptomatic and a close household contact, that means the yield of the virus would have been considerably less. So it is better to do an RT-PCR. But if the patient is having symptoms like this, which is obviously could be a virus for coronavirus and a close house contact, then you can get the test by a cheaper test of the rapid antigen test. Right? Now, we classify the disease severity as mild, moderate, and severe. The mild disease is fever, sore throat, rhinorrhea, cough, diarrhea, vomiting, and no fast breathing. And in moderate disease, in addition to these symptoms, there is fast breathing, which is age-based. By age-based, I mean in a child less than 1 month, it is 60 breaths per minute. In between 1 to 12 months, it is 50 breaths per minute. In a child from 1 to 5 years, it is 40 per minute, and more than 5 years, it is 30 per minute. Or the presence of hypoxia 90 to 94 on room air and no signs of severe disease is a moderate disease. And severe disease is all these symptoms of moderate disease plus pneumonia. With any of these, less than 90% increased respiratory effort, in addition to the tachypnea that I have told, is the increased respiratory effort, grunting, severe retractions, lethargy, somnolences, severe diarrhea, and in a critical patients, they are the ARDS shock, the multi-organ dysfunction syndrome, and acute thrombosis. Next slide. Now, this is the treatment module for COVID-19 in children. This is also given by the Indian Academy of Pediatrics. It might look overwhelming. The slide might look overwhelming, but you can see that you have to just look at the mild and the moderate disease. The severe disease can be left to the pediatric intensivists. The mild disease, there is practically no treatment. Just keep the patient at home. Look at his hydration. If the baby is being breastfed, continue the breastfeeding and look after his nutrition. And no antibiotics are required. But if there is fever, you can give paracetamol. If nose blocked, then normal saline nasal drops. And if there is high grade fever for more than 3 to 4 days, then you have to look. This is a very warning signal. And the red flag signs are rapid breathing, SpO2 95, SpO2 less than 95, persistent fever, lethargy, drowsiness, and poor feeding. The moderate disease is, if there is a moderate disease, you have to admit in a if there is a moderate disease, you have to admit the patient in a COVID-19 ward and investigate at the CBC, RFT, NFT, CRP, and it must be repeated every 48 to 72 hours. SpO2 more than 94, hydration, paracetamol, antimicrobials. SpO2 less than 94, you have to do the full gamut of treatment: oxygen, steroids, remdesivir, and antimicrobials. Severe, in case of severe critical disease, they should be admitted in a COVID-19 ICU ward. All these investigations needs to be done, and the patient should be in prone position. IV steroids and remdesivir plus enoxaparin plus antimicrobials should be given. Now, these are the doses of remdesivir. I have never used remdesivir, so I won't be talking on this. The steroid dose is 0.5 mg per kg per IV. Next slide. Now, this is a peculiar syndrome, multi-system inflammatory syndrome in children. This occurs in about 1 or 2 patients per lakh of population. The definition of MISC is a very rare syndrome, but you have to know this because it is very peculiar to children. And the definition of MISC is from a children between up to 19 years old, any fever more than 3 days, and 2 of the following: rash or bilateral non-purulent conjunctivitis, mucocutaneous inflammation, signs of the hands, oral, and or the feet, hypotension or shock, features of myocardial dysfunction, evidence of coagulopathy, acute gastrointestinal problems, and elevated ESR, C-reactive protein or propulsivin, and no other obvious microbial causes of inflammation, and evidence of COVID-19. Next. Now, this is the third wave. Now, if you look at the metaphor that this is a tranquil sea, but there are some ripples going on. Normally, there is an endemic state, some amount of infection will always be going on. But when a large amount of cases occur, then in a particular locality, then you can say that the there is a wave of the disease which is causing the epidemic. Now, what the question is usually asked, will there be a third wave? That is the first question that is asked. And the third wave, the answer to that is that because there was a first wave and the second wave, and the pandemics always occur in waves. Large number of cases occur suddenly, and many people get immunized because of natural immunity, and then they are not susceptible to that particular disease, and then the wave stops until again large number of susceptible patients are available, and again the second wave starts. So on and so forth. The wave goes on. If the third wave is going to come, it is very likely that it is going to come. Next slide. There is a possibility of third wave, but you can never predict the severity of it. Next slide. Now the next question is, are children susceptible to the third wave? Now it is hypothesized that the first wave was for adults, for the elderly and the comorbid conditions. The second wave, large number of young adults were affected. So therefore, there was no. So therefore, they were not. Children were not affected in this, and now the children are susceptible. So therefore, the children are more likely to develop corona infection. But that is not the case, because 25% of the children had seropositivity as much as the adults, which suggests that children already had the infection, asymptomatic or pre-symptomatic or very mild disease. So therefore, they were not susceptible to it, and we can safely say that children are as susceptible as adults to develop infection, but not a very severe disease. Next slide. It is very highly unlikely to be predominantly or exclusively affect the children. Next. Now, this is the most important thing. We should be careful how the mutant virus behaves. We genuinely don't know how the mutant virus will behave. First, there was the alpha variant, then the delta variant, now the double mutant, double delta plus variant. So many variants are there. It constantly keeps changing. How the virus behaves is always an X factor. We can never estimate that. So therefore, the dictum is be prepared for the worst and hope for the best. And this is the statement, this is a consensus statement given by the Indian Academy of Pediatrics of the third wave. It's the viewpoint of the Indian Academy of Pediatrics, and it's fairly correct. Next slide. So what are the preparation precautions in the anticipation of the third wave? The next slide. Most children have mild disease. We have seen that. Next. Now, educating the parents regarding the illness and the warning signs, I have already described that. So this parents should be educated about the warning signs. Arranging for more special COVID wards for children and PICU. Now this is the easier part, because you can arrange the COVID wards and the PICU. But the more difficult part is to find. The more difficult part is to find pediatricians and specialized training nurses, because pediatric nurses has to be specially trained for that. They have to know how to put an IV, and they have to know what about the ventilatory settings, and so on and so forth. So the human manpower is the more important, crucial decision which has to be made, rather than a special ward and ICUs. Parents are role model of sanitization, masking, and social distancing. Children are great imitators, and therefore they will always follow the whatever the parents do. There is a need to vaccinate children, because even though they do not have a severe disease, some of the children have a severe disease. And in Pune, I think I just heard 2 pediatricians who had patients in an ICU, and both of them recovered very well, and there were no deaths actually. But even then, it is necessary to vaccinate the children. The reason for that is that after the elderly and the young patients, the children will be the only vulnerable population which will be left. Even though they do not have severe disease, you can simply protect them by vaccination. And there are 2 vaccines which are in the pipeline. The first vaccine is the Covaxin, which is trial of which is being done in children, which is going to be available by the month of October or November. And the next vaccine is by Zydus Cadila, which is called as Zykov. But this vaccine is given intradermally, and the advantages of intradermal is that it can be given in very small volume. Because they are given in very small volume, like 0.1 ml, more number of children can be covered with this. Next slide. What are the challenges of the third wave? Vaccination at great speed. This vaccination at great speed, we had on Yoga Day of 31st of June, nearly 85 lakh people were vaccinated. But this vaccination has to be every day has to be Yoga Day for this. And the next day to the Yoga Day, there was only 50 lakh vaccination. But you have to continue at least at 50 lakh population getting vaccinated till 31st of December. It is supposed to be the deadline. Then maximum of around 90 crores of people will be vaccinated. Next, next is the tackling the vaccine hesitancy, which is not very much there in the Indian population, but the vaccine hesitancy is there in the European countries or in America. But we don't face this problem. What we face is the vaccine lack of vaccines. Next. Now again, this virus variants. This is the crucial part, the X factor. We do not know how the virus will behave. So therefore, this virus, when it changes variants, they will always lead to more infection. And the danger is that they may escape the immune system. So therefore, the persons who have had a first viral infection may again be susceptible to the next variant virus. And what is the treatment protocol? These treatment protocols keep changing. The treatment protocols keep changing. Firstly, there was hydroxychloroquine, then there was ivermectin, and then there was remdesivir. Now, remdesivir is not of any use, or then again have say that ivermectin is of no use. I believe, in my personal experience, that ivermectin works at least to decrease the severity of infection. And this there is also the only drug which is proved is oxygen. Oxygen is the only drug which can be given. It is scientifically proved. Next. So we have the challenges of school learning. The physical and psychosocial health is more important than formal learning. So this formal learning, the physical and psychosocial mental health of the child is more important than formal learning. The school reopening is based on local epidemiological indexes, that is less than 5 case positivity rate continuously for 2 weeks. The parental willingness to send the school is the crucial factor which decides when the school should be reopened. The school, whenever it is opened, it should have a flexible timing and it should open in shifts. That means if there is only from 12 to 5 o'clock, it should be from 10 to 4 and 10 to 1 and from 2 to 5, something like that. 3 hours shift should be there. And every child should sit on one bench and they should not share the notebooks, etc. There is a concept of ring immunization which is very important. Every person of the child who is with the interacting with the child, the school principal, the school teacher, the peon, the bus driver, the attendant in the bus, the parents, everybody elderly in the person should be immunized so that they have got some sort of a suraksha kavach around them. Next slide. Now, this school reopening is a long way off because those epidemiological indexes are still not being maintained. So the guidelines for remote learning. So remote learning is resorted to. The focus should be on developing skill sets curriculum adapted suitably. That means there should be the curriculum should be on a mandatory to know, need to know, and nice to know. These are the 3 factors which should be considered. The special care should be taken for marginalized children. Now, these are the marginalized children. They are sitting on the floor with a computer and see the green on their faces. So these children, maximum number of attention should be given by the government for these persons, and these are the persons who can't afford a Baiju education. Government should come up with exclusive TV channels only for these people. The screen time is 30 minutes for the pre-primary children, and 2 sessions of 30 minutes each for 1st to 5th standard, 30 to 45 minutes, 3 to 4 sessions for 6th to 12th standard. Now, if they normally I have asked around and they are exceeding this, and there might be some cases of eye strains, and you may have to use the blue filters or blue glasses, anti-glare glasses. Next. Now this is a beautiful Sanskrit sloka about learning process in itself. Acharya Padamadate Padam Shishya Somedaya Sabrahmacharibhya Padam Kala Kramena Cha. 25% of the learning is through by the teacher, 25% by the self-study Swayam Adhyaya, and 25% is from the classmates, and 25% is with the fullness of time. Now, in this school epidemic, this Acharya Paramaditya, this 1/4 from the teacher is also curtailed because the curriculum itself is curtailed. Swayam Adhyaya, they should get it from the encouragement is from the teachers, and then are from the classmates. Both are absent, and uh, Kala Kramena, of course, this is 1/4 which time it is always been existing. Next slide. Now, we should have a sense of humor for this. I'm speaking in Patrakar Bhavan, but I know everybody has said humor. And I don't know when the COVID epidemic will end, but I do know that my talk is going to end. Next slide. My time is ending right now. So this is a little child who is giving to a flower with her arms outstretched, maintaining social distance. She has hidden her face behind the flower, and I can assure you that behind the flower, she has got a very beautiful smile. And let us hope that we come out of this smelling roses. Thank you very much. Thank you for patient hearing.
Thank you, Dr. for your talk. You have almost covered all the topics about COVID, about children, but and also you told us about the school children, how they should be followed, how they teachers should follow them. So it was a very nice session. And I just wanted to know, I don't think will not be used to the children.
I'm not
Can
looking
be.
into it, so I don't think those parents of the children, they usually bring you or relatives.
In the audience, could we can ask the patient because there are.
Yeah. हो ते प्रॉब्लेम आहे ते दोन बोट घेऊन करायला लागतं.
So what about influenza vaccine?
The influenza vaccine will protect against influenza. It won't protect against coronavirus, but it should be given nonetheless because the influenza vaccine, if the influenza cases in the community decreases, the strain of the public fever, it will not be possible to diagnose whether it is influenza or not. So if the influenza cases decrease, the system load on the system will be decreased. So that is the reason why influenza vaccine should be given, not for coronavirus. If you any vaccines you can give on the same day, you can give 3 vaccines, 4 vaccines on the same day. But normally, if you want to give another vaccine, you have to wait for another 1 month or at least 28 days.
Sometimes cat scratches or dog bite patient. And what should be the difference between the cat between this vaccine?
If there's a cat vaccine, you can postpone the routine vaccination for some time. That is not a problem. Routine vaccination can always be postponed. Yeah. Regarding what? Below 1 year, I think they will take a long time to come. And the mother has got breast milk antibodies, so they will be protected. Just let us look at the patients first. You have to go stepwise. Thank you.
Thank you very much, sir. What I understood from your lecture is be prepared for the worst, but don't keep your hope, keep the hope very best. So thank you. Now I request GPA President Dr. Shivaji Kole to felicitate today's speaker, Dr. Vishnu Hegde, sir. Thank you, sir. I request GPA President Dr. Shivaji Kole to felicitate today's chairperson Dr. Nas Parveen Inamdar. I request GPA President Dr. Shivaji Kole to felicitate our chairperson Dr. Meenal Pawar. Thank you, Kole sir, both chairperson, and special thanks to Speaker Dr. Vishnu Hegde sir. Thank you. Now we move towards our next lecture. Our next speaker is Dr. Chitra ma'am. I invite Chitra ma'am on the dais. To chair this session, we have our GPA family member, Dr. Trupti Joshi. She is a BMS practicing in Kothur since 20 years. She worked as a lecturer at DMLT College, Kolhapur, and she is a former president of Kothur Doctors Association. Our second chairperson is Dr. Sandeep Nikam. He is BMS practicing at Balgaosheri since 20 years. He is doing all the government pediatric vaccinations since last 15 years. He was a past secretary of VCKDA. He is a managing committee member of GPA. Over to you, Dr. Trupti Joshi.
Kind words. It is my pleasure to introduce our regional speaker, Dr. Chitra Sambre Madam. She holds degree of MS FRCS, that is Fellowship of Royal College of Surgeons, Edinburgh, UK, MD Genetics of Glaucoma, King's University, UK. Dr. Chitra Sambre is comprehensive ophthalmologist with a specialty interest in cataract, glaucoma, cornea, and ocular surfaces. Trained in prestigious institutes in UK and in India. She offered her services in National Health Services Hospital in UK for 15 years and has been offering services in Pune for last 8 years. She has extensive clinical and surgical experiences of working in ophthalmology and has performed innumerable phaco-cataract surgeries with a premium intraocular lenses in the UK and in India. She has been routinely performing advanced lamellar corneal transplantation procedures, stem cell transplantations, new treatment for keratoconus like cross-linking, and in technology-assisted cataract surgeries with refractive procedures like LASIK for removal of glasses. She is a motivated researcher and has won Sir John Wilson Fellowship Award from British Council for prevention of blindness for her collaborative research on genetic in glaucoma in Indian population. She has presented papers in various reputed international and national conferences and has many publications in peer-reviewed scientific journals. Now I request Dr. Chitra Madam to enlighten us with her knowledge and experience.
Hello. Good morning, all. Thank you, Dr. Tripti, for this generous introduction. And I really am thankful to the General Practitioners Association, Dr. Kole, Dr. Shubhida, for inviting me to this forum. It has been a pleasure to be amongst all you physically after a long, long time. The topic which I started off was common eye problems, which everyone faces, and how do we deal with them? How do we tackle them? Now, when I thought about it, I thought, well, these problems which were common till 2020 are no longer common in this COVID era. They have got a different dimension and have to be dealt with in a very different way. The most common problems with which the patients present to us all are red eye, loss of vision, may or may not be associated with pain in the eye. Now, if we ask for the causes of red eye to any student of medicine, they'll go on with trauma, infection, allergy, acute glaucoma, corneal ulceration, and so on. However, a patient comes to us with red eye, we think about infection all the time. First diagnosis, whether it is an infection. Now, we do get even now patients coming with red eyes. It was this doctor who was Wang Guangfa he is a pulmonologist from Peking University, Beijing, who was treating all the COVID patients and got infected due to COVID. And the first symptom he had was conjunctivitis. He was very vigilant. He covered himself nicely with all PPEs, but he hadn't covered his eyes. And then he postulated that, yes, corona is, it can enter the body through conjunctiva. And then the whole world thought of it. Well, yes, the virus can get into our system through the conjunctiva. So it presents like a viral conjunctivitis. Patient gets congestion, watering, lymph nodes sometimes, redness, pain, but it is also associated with other COVID symptoms. So any patient who calls you with red eye or comes to you with red eye, be cautious. It could be COVID, potentially COVID patient. And we have to ask other histories of associated COVID symptoms in this patient. I did have a patient calling up for red eye. Patients are reluctant to tell you whether they have fever, they are having other COVID symptoms, but you have to probe and ask. And well, they want prescription over the phone, you just tell some antibiotic. And a few days later, she called me that every member in the family had suffered from COVID and all had conjunctivitis to begin with. So a word of caution. Now, this has to be differentiated from other forms of conjunctivitis, which is very easy, as we all know. Bacterial conjunctivitis has purulent discharge, whereas allergy, you have history, and eye rubbing or itching, which is a hallmark of allergy. So we have to ask for all these symptoms before we come to conclusion. Well, this patient with red eye could also have iritis, uveitis, and the patient has extreme photophobia, pain, and redness. Iritis can also be associated with this conjunctivitis. And it starts with conjunctivitis and can lead to, can spread inside and cause iritis also. So that this patient has to be examined on slit lamp. And as you can see, these are the cells which are deposited on the back surface of the cornea, which can be seen only with slit lamp. So iritis, when a patient is with iritis, well, we have to keep COVID in mind and also see if there are any association. Well, we can't forget all these routine things. Is there any ankylosing spondylitis, arthritis, or is there any infection? Because all these conditions can also get exaggerated due to COVID, mostly post-COVID, particularly if they have plenty of steroids. So all the infections can flare up and patient can have granulomatous iritis. So not all eyes are conjunctivitis, not all eyes are plain conjunctivitis, could be COVID conjunctivitis. So all have to be dealt with caution. So patients, well, if they are not admitted, we can see them on slit lamp. But patients from ICU have also been referred for red eye and they have conjunctivitis and iritis. And not to forget that all these patients who are being treated for COVID and having all these immunosuppressants, steroids, can have flare-ups of cytomegalovirus and other viral infection, which can lead to uveitis, retinitis. So this is a patient who got CMV retinitis, and that causes complete necrosis of the retina and blindness. Well, we can't forget simple things. Mask-associated dry eye. People say that the carbon dioxide you emit can just go into the eye and cause dryness. So you don't forget to pinch your nose once you put the mask on. Also, as Hegde sir said, the screen time has increased and lots of patients are coming with increased refractive errors as well as red eye due to dryness of the eyes. So a simple thing to tell them is every 10 minutes go off the computer, blink 5-6 times, look out of the window, and but take all other precautions. Check if you have a refractive error. If you are working for long hours, particularly in the computer users, they have been working from home for long hours, so they should also supplement the eyes with lubricants. So these are the tests which we perform and come conclusion to the whether the patient has dryness. So red eye, remember, could be a red flag. So deal with it very carefully. If the patient didn't have COVID, stay slightly away from that patient, be careful, and then assess and then decide on your line of treatment. Now, the second common complaint which the patients present to us is the loss of vision. As we all know, thromboembolic phenomenon are very common after COVID, and lots of patients are coming up with central retinal vein occlusion, branch retinal vein occlusion, and central retinal vein occlusion, as well as, remember, all these patients have been sitting at home due to the fear of COVID and no one attended routine ophthalmology appointments. So particularly the diabetic patients, they have developed proliferative retinopathy. They're coming up with vitreous hemorrhages and lots of new vessels on the retina. So they have to be seen quickly. As same with age-related macular degeneration. So this is a patient who has a central retinal vein occlusion. Patient has sudden loss of vision. Hypertension, diabetes can be associated with it, and these are the risk factors. And there are two types of it actually. If it is ischemic, that is, if it is severe and causing ischemia to the retina, it's a non-reversible blindness. If it is non-ischemic, after the macular hemorrhage is clear, patient can get some vision back. As we all know, artery occlusion, central retinal artery occlusion, it's like having a mini stroke to the eye. Well, it's a major stroke to the eye, but it's mini as when you consider the whole body. So it's a stroke to the eye, and one has to be cautious. The patient, if comes to us with CRAO, has to have carotid Dopplers, profile, and all the precautions as we take in stroke. They have to be given aspirin tablets straight away, 150 milligram, and then 25 milligram, of course, in consultation with physician for the same. Patients can present with non-arthritic ischemic optic neuropathy. Now, there was a similar patient. This is not the picture of that patient, but we had a patient who was 42-year-old, young, very anxious, type A personality. His blood pressure suddenly shoot up as soon as he learned that he was RT-PCR positive. He was admitted to ICU and said that he can't see at all. And he had developed ischemic optic neuropathy due to hypertension. What they present with is sudden loss of vision and an altitudinal defect. So they can't see half of the horizontal half of the vision is gone. This is also permanent. But I mean, this patient was, because he was in ICU, he was treated for that and he recovered, thankfully. So points to remember from this is, if it's a red eye, be careful. It could be COVID if the patient didn't have any vaccines or didn't have any infection before. If the patient had COVID, well, it could be a complication and it could be very serious. Reduced vision, the patient should be seen and assessed even for his general health and for his eye problems with an ophthalmologist. So with all this, the ophthalmologists all became very scared. We didn't have any work for about a year because no one came for routine eye checks. So everyone became desperate, and then people started researching, well, is the virus present in the tears? There was a big research conducted, and they found out, they took serial samples of the tear and found out that the virus cannot lodge in the tears. It just gets into the conjunctiva and gets across. Then our routine surgeries, phacoemulsification, it generates aerosols. So can we get infection through that? Can we get infection when we do pneumatic tonometry? Well, all came with negative answers, so that was a good thing. And we started with all precautions. As you can see, the distance of examining the patient is so less that it's really, really scary. So we took all the precautions of cleaning and all and started our work. And soon came this black fungus. It was like a battle within the war of COVID. So we got all these patients coming with different eye complaints, and it was all over India. Really, this mucor, it created havoc. This will be discussed by Amol, so I'm not going to discuss in detail. This is a slide from a microbiologist. It has a branching pattern, typical branching pattern of KOH as you can see, and it can grow anywhere. It's ubiquitous organism. It is present everywhere and only affects if your immunity is compromised. The incidence was not as much, but the mortality was very high. And if we delay the treatment, the mortality increases. Now, why we are so much scared of this mucor is because it can cause complete loss of vision. It can affect anyone, even young patients. Loss of eye, loss of orbit can lead to permanent disfigurement, and it's really horrible to even perform these operations and see these patients. It can spread to the brain and cause abscesses. It can cause life, it can, take off the patient's life. Mortality rate is up to 52 to 54%. And if the central nervous system is involved, the mortality is even more than 80%. So because it was so commonly seen, it was like an epidemic almost within it. And it became like a notifiable disease to the government registry, and we have to notify all these mucor cases now. The mucor, it invades the blood vessel. It causes thrombosis, and then it grows nicely on that necrotic area. How does it enter the orbit? Well, there have been lots of theories, but then it, of course, of how it affects the patient. But when it does, it goes through the nasal mucosa, it can go through the nasolacrimal duct, through the sac and go into the orbit, or it can cross the ethmoid and get into the orbit and get to the orbital apex. From there, it can go invade the brain. So the patient can have nasal stuffiness because the mucosa is the first which is affected, then pain, headache, bad odor. It is a black fungus and it does emit bad odor. There can be periocular edema, facial edema, just because of the inflammation. There can be eyelid discoloration. You can see black scars on the eyelids. Now, if the infection gets to the orbital apex, it can affect the third nerve, cause ptosis. There can be proptosis because of inflammation within the orbit. The orbit doesn't have, the orbit bony cavity is small, and the inflammation can just swell up the tissues and the eye proptose or bulges out. There can be ocular motility problem because of involvement of the muscles and also the nerves at the orbital apex supplying these muscles. The patient can suddenly get blocked artery because of invasion of the artery, like the central retinal artery occlusion, or also a superior ophthalmic artery occlusion. This can cause complete visual loss. It can cause no PL in a patient. So a patient can see sometime before breakfast, after breakfast, he gets an artery occlusion and it's complete loss of vision. There can be nasal discharge. There was one patient who came with loose teeth, had loose tooth, had teeth problem, and hence he was then diagnosed of mucormycosis. So, who is at risk? Well, patients who receive steroids. This is the first thing. And there is a study which has been published now and which I'll talk about later, which says that steroids responsible for about 90%, used in 90% of these cases. Hyperglycemic tests state tocilizumab, immunocompromised patients, patients in ICU, and then people started postulating lots of things: excessive steam inhalation, breaking of the nasal mucosal barrier, where contaminated oxygen and all. We have to investigate this patient. The microbiology is in the form of KOH, biopsy, histopathology. I'm just touching on it because it will be dealt with later. The PCR would be diagnostic, but most of the mucor is picked up on KOH very nicely. Now, presentation. Patient can present with minimal congestion and chemosis. Look at this congestion. She will not have any symptoms. So she didn't have any symptoms actually. Little pain on the side of the eye and congestion and chemosis. And when she came to us, she was then found, had MRI, endoscopy, and that then was found to be a mucor. Whereas this was the patient who came with all this discharge from the nose. Then there was proptosis, chemosis, and the whole eye is bulging out. No movements of the eye, orbital apex is involved, complete ophthalmoplegia is there. So it's a very severe presentation. This is another patient who had face and you can see just a minimal condition. The patient on the right side has just ophthalmoplegia, whereas the patient who is in the photograph down has complete ptosis and complete loss of muscle movements. Now there are MRI just displays very classic signs: nasal paranasal thickening, ischemia. The middle turbinate is the first one which is affected, and it shows the black turbinate sign, thickening of the muscles, enhancement of the orbital fat, orbital apex, bone destruction. All these features are seen. Now, an extensive staging was done to see whether that helps in management of the treatment. Stage 1 was involvement of the nasal mucosa. Stage 2, involvement of paranasal sinuses. Stage 3, involvement of orbit, and stage 4, involvement of CNS. Now, other things were also considered: signs, symptoms, and all. When the patient comes with mucormycosis, we always adopted to this multidisciplinary approach because it has to be, if it has to be done properly, other doctors, physicians, infection specialists, ENT surgeons, they all have to work in team. So the patient presents to us as ophthalmologists because the patient has eye problems, refer to ENT surgeon who does endoscopy and diagnosis. The ENT surgeon is a key person in this. Then also the maxillofacial surgeon, because the palate can be involved and maxilla can be involved. Then there's infectious specialist who looks after whether there are other infections, how bad is the infection, how is the kidney status. As we know, ampho-B is very nephrotoxic and can cause the patient's life if we inadvertently use it. And so the patient has to be admitted. It's a very costly affair to get mucormycosis because once we operate on this patient, again, the patient has to be shifted to the ICU. We got a few patients who were already in ICU who suffered from mucor and had an extended stay. So lots of surgeons in the OT. And you do see all this necrotic tissue, which is very nicely removed by ENT surgeon. And I'm sure Amol will have nice videos for you. Now, if it affects the orbital affects all the nerves are involved, fourth, fifth, sixth. So there's no sensation of the cornea or no movements. There is complete ptosis and there is no vision because the optic nerve is also involved. This is because of that the anatomy, which is very crowded at the optical apex. So what do we do for management of the orbital mucormycosis? It has to be done in combination with ENT procedure, that is debridement of the paranasal sinuses, and we can irrigate with ampho-B Well, if it is patchy, we can just give transcutaneous retrovalvular amphoby. And the last option is exenteration. So this is amphoby, we can prepare, it can be either deoxycholate or liposomal. Give under all aseptic precaution, give lignocaine 1 ml and then give this 1 ml amphoby injection on the medial side, on the lower side of the orbit, because it's on the medial side that we get the infection spread from. Now, this is another patient who just came with swelling on the maxilla, periocular swelling, underwent phase for 2 times, and then he got better. I saw him just a day before. He had restriction of movement. All the movements have come back, and his vision is 6/9. So they do really well if we catch them in time. This is another patient who had undergone phase, and he's recovering from the infection. The patient with spectacles has complete ophthalmoplegia, no PL, but has no signs left now in the MRI. The third patient just read newspapers and came because he did have some diplopia and he was also caught in time and dealt with in time. Now, the patients, they survive, the stage passes on and they develop what is called as neurotrophic corneal ulcers because the cornea is not sensitive. So they develop corneal abrasions and amniotic membrane have to be done. I had a patient who had mucormycosis after the first wave, and she has this neurotrophic keratitis and had to do amniotic membrane graft for this patient. What is the cause of loss of vision in this patient? As I said, blockage of the central retinal artery. I mean, you can see all the blocks, thrombi in the arteries. I don't know if the picture is very clear, but the white arteries are small little thrombi logging on, and that causes complete loss of blood supply to the retina, to the optic nerve. Also, it is because of compression. Second cause is due to the compression of the optic nerve due to the inflammation within the orbit. And such patients have some vision, at least counting fingers. These patients who have complete blockage of the artery have no perception of light. If it is due to compression, due to the inflammation, we can do decompression. I mean, the ENT surgeons do a fantastic job of doing decompression of the orbit, taking out the periosteum, the eyeball settles down, and even the vision improves nicely. So this is a very bad operation. As I said, this was a patient who was very unlucky, had everything involved, maxilla, teeth, orbit, everything, and underwent exenteration. It's a very ghastly operation, but unfortunately, he didn't survive. This is a young patient, and as because he was very young, and because the orbital involvement was very patchy, we decided not to do exenteration. But later on, sadly, he did develop all the scars on the lid, and there was ocular involvement. I mean, this is the only patient in whom I have seen black fungus getting into the globe of the eye. We did exenterate him, but later on he was in ICU. He was serious. He developed all infarcts all over the brain and sadly died. So it was very important because of these cases to compile the data and see what happens. I'm very happy that I contributed to this study, which is published in the Indian Journal of Ophthalmology. And this was the patients were collected from all over India. So there are about 100 authors to it. And this is a cosmic study, and they looked at different causes and different, different modes of treatment used in these patients. So from all over India, data was collected, and 2,826 patients were included in this study. As you can see, Maharashtra is almost highest, 21%, just near Gujarat, and had highest number of patients. 51.9 years was the average age. Males were predominantly affected. 57% patient had oxygen support. 87%, that is, you can say almost up to 90% of the patient received corticosteroids. So this is a big culprit. And about 78% of the patient were diabetic. Well, whether they were diabetic or not, we can't say they were hyperglycemic. Is it hyperglycemia due to steroids. So steroid was the thing which brought in Mucor as per this paper and as per many people's opinion. So most of the patients, as you can see from this, 56% develop within 14 days, but 44% develop even later, in the later period. It included ampho-B injections, orbital exenteration was done in 15%, and ampho-B was administered in about 22% intraorbitally. So intraorbital injection was given. Mortality was 14%, and stage 3B, that is more than orbital involvement, the prognosis was very poor. Orbital exenteration, when the disease was severe, it reduced the mortality from 52 to 39%. And as I said earlier, corticosteroids and diabetes are the most important factors. Now, these are not my patients, to be honest. This is just to show that this is an exenterated eye and one can have an ocular prosthesis fitted on. Even they can fit it on to the spectacles and make the patient's life simple. So it is a long process. Now, not to forget that these patients, because they didn't turn up to us, are coming up with hypermature cataract, lens-induced glaucomas, and advanced glaucomas because they haven't been looked after. They're coming with loss of vision. Also diabetes because of all this hyperglycemic states, corticosteroids, and not having treatment. A lot of patients are coming with new vascular growth, vitreous hemorrhages, and advanced proliferative diabetic retinopathy. So it's important to motivate all these patients to get seen for diabetic retinopathy and other eye problems too, because they need laser treatment and other treatments quickly. So of course, COVID is a monster, this Mucor is a monster, but we cannot also forget good monsters like cataracts and other things. Thank you very much. Yes, yes.
Generally, सर्वच पॅरेंट्सला हा पडलेला प्रश्न आहे की आता सध्या ऑनलाईन स्कूल चालू आहे, संध्याकाळी प्रायव्हेट क्लासेस आणि दुपारी अकराचे बोलणं गेमचा प्रश्न पडला की आता काय आहे, डोळ्यांची वाट तर याच्यावर तुम्ही काय मानता?
या आता ते म्हणजे पेरेंट्स आर ऑल्सो ॲट अ लॉस की शाळेचं शिक्षण त्याच्यावर आहे म्हटल्यावर काही बोलता येत नाही. बट इट्स इम्पॉर्टंट टू रिस्ट्रिक्ट द स्क्रीन टाइम आणि मुलांना सांगता येत नाही, पण थोडासा ब्रेक म्हणजे टू ऑल कम्प्युटर युजर्स वी से दॅट कम्प्युटर विजन सिंड्रोम विच इज व्हेरी कॉमन अँड फॉर दिस ड्रायनेस अँड आय प्रॉब्लेम्स त्यांना आम्ही सांगतो की दर 15 मिनिटांनी तुम्ही डोळे कम्प्युटर बाहेर करा, ब्लिंक करा 5-6 वेळा, दूर बघा आणि मग पुन्हा कम्प्युटरकडे बघा. हे एक फॅक्टर झाला, कारण ब्लिंकिंग इट स्प्रेड्स द टिअर फिल्म आणि ब्लिंकिंग झालं नाही तर ते टिअर फिल्म स्प्रेड होत नाही. वी स्टेअर एट द कम्प्युटर्स अँड दॅट कॉजेस ड्रायनेस. दॅट इज वन थिंग. सेकंडली, यू आर फिक्स्ड ऑन द कम्प्युटर ऑल द टाइम, त्याच्यामुळे कॉन्व्हर्जन्स स्पॅझम होतं. That causes trouble. That can cause refractive errors. So all these problems can crop up. Then we should make sure as parents that they are sitting in a well-lit room. एकदम एसीच्या समोर, पंख्याच्या समोर, फायरप्लेस ह्याच्या समोर वगैरे नको. चांगलं व्यवस्थित ह्युमिड वातावरणात राहावं, लाईट ॲडिक्वेट राहावा. There should be anti-glare sort of screen on the computer. छोटे छोटे पर्याय आपण करू शकतो. And maybe it's important to form a small bubble and live within that. मुलांना बाहेर खेळायला लावणं, आपल्या चांगलं सूर्यप्रकाश थोडा मिळणं, very essential things I think.
जनरल प्रॅक्टिशनर्सला जनरल आणि कोरोनाशी रिलेटेड
ते डिफरेंशिएट करणं थोडं कठीण आहे. आणि आय सेड अर्लियर, व्हायरल कंजंक्टिव्हायटिस असतो, सो दॅट द सिम्पटम्स आर लाईक व्हायरस कंजंक्टिव्हायटिस. यू गेट वॉटरिंग फ्रॉम द आईज, रेडनेस असतो, डिस्चार्ज नसतो जो बॅक्टेरियल मध्ये असतो. खूप इचिंग नसतं जे ॲलर्जिक मध्ये असतं. So these things we differentiate from other viral, from bacterial and other allergic conjunctivitis. But coronavirus conjunctivitis and other viral conjunctivitis, it is difficult to differentiate. One important point which I would like to stress is just give a very common broad spectrum antibiotic. If at all you want to, you can give some lubrication along with that. The lubricant is important. And a broad spectrum like chloramphenicol, don't give steroid because that can just spoil everything and even at that stage. And inadvertent use of steroid drops also can lead to lots of problems like glaucoma, cataract, and all. Of course, आता नाही कारण ते थोडे दिवस टाकून बंद करतात. But leave the steroids to the discretion of the ophthalmologist. And because it's the patients and the pharmacists. Patients feel better. Pyrimon was the drop. It was like used very widely for any problem, and the patients go to the pharmacy and they give this drop. It's like a magic drop because it has steroid and it has balloons. Patients feel better. But that's not the way to go forward. And we have patients who have been using this drop for months, years. And about 25% of the people who use steroid develop glaucoma. That's a very high risk. त्याच्यामुळे it's very safe to give some bacteriostatic like chloramphenicol for काहीतरी lubrication, some symptomatic. Second important point is in COVID-related conjunctivitis, you must probe to see whether the patient has associated with other symptoms of COVID, whether there's any other member in the family or whether he has been in touch with COVID patients. हे सगळं विचारून थोडं आपल्याला करता येतं. Important point is if the patient didn't have any vaccine, didn't have COVID, तर आपल्या स्वतःलाही आपल्याला काळजी घ्यावी लागते. Yes. The newborn babies with conjunctivitis, he said, newborn babies with conjunctivitis is a totally different topic because he or she can carry a vaginal infection of the mother. So if it is with profuse discharge, it can be a gonococcal conjunctivitis. All newborn conjunctivitis, as a rule, should be they should have a swab and tested in the laboratory. You shouldn't give chloramphenicol in children, and you shouldn't give very high antibiotics in children. So the safer would be just like erteric moxifloxacin is safely used nowadays in children. Although it is high, it is safer. That's why it is recommended. But just remember, it could be gonococcal, it could be herpes related, it could be with other things. So taking swab from these children is very, very important. That's one of the indication of conjunctivitis where swab should be taken. Thank you very much. Thank you.
Thank you. लाईट ऍडल्ट्स आता मुलांचं देखील वर्क फ्रॉम होम चालू आहे त्याच्यामुळे स्क्रीन टाइम नक्कीच वाढलेला आहे. सो ॲज मॅम सेज प्रिकॉशन इज ऑलवेज बेटर दॅन क्युअर. So thank you very much. Now I request GPA President Dr. Shivaji Kole to felicitate today's speaker, Dr. Chitra Samre ma'am. Thank you, sir. I request now Dr. Shivaji Kole to felicitate today's chairperson, Dr. Trupti Joshi and Dr. Sandeep Nekar. Thank you for chairing this session. Thank you very much. Moving towards our next academic session, we have a great speaker, Dr. Sudhir Kumar Munde sir with us. To chair this session, I invite Dr. Rajesh Doshi and Dr. Prerna Brave on dais. Dr. Rajesh Doshi is a BHMS working as a family physician since last 19 years. He is a founder and vice president of social welfare organization. He is a panel doctor at Sancheti Hospital. He received Best Zone Coordinator and Best Secretary Award by Jain Social Association. Welcome, Dr. Doshi. Dr. Prerna Brave, she is a BMS. She is a yoga physician. She is practicing since last 20 years. She has conducted yoga for doctors, for students, and for corporate sectors. She published many articles on the same. So I hand over charge to today's chairperson, Dr. Rajesh Doshi.
Thank you, ma'am. Good morning to all. It's my pleasure to introduce Dr. Sudhir Kumar Munde, sir. Sir has done his MD in medicine from Jabalpur University in 1987. He is practicing in Pune since then. He is presently director of Shashwat Hospitals and has conducted numerous tutorials and CME for general practitioners and students. He is an amazing flute player who plays flutes just like Lord Krishna. Where hears him plays is mesmerized by it. With Melissa giving lecture on post-COVID syndrome, how to care for the Melissa. Thank you.
Thank you so much for the kind words. Mask खाली करो ना. नहीं ऐसा खोटू फैला है कि Anyway. Thank you very much for the kind words. तर डॉक्टर सांबरे जसं म्हणाले की स्क्रीन टाइम असं बघत राहिलं की डोळे ड्राय पडतात आणि त्यातनं पाणी टीयर घ्यायला पाहिजे, ड्रॉप्स टाकायला पाहिजे. आता डॉक्टर हेगडे आणि डॉक्टर सांबरे यांनी स्वतः इतकं छान लेक्चर दिले की डोळे आपले उघडेच राहिले होते. त्यामुळे ड्रॉप्स आणले असते तर बरं झालं तसं बरं. So today's topic is of course a very burning topic, and as family physicians आपल्याला या वर्षीच नाही, maybe another couple of years we will be taking care of post-COVID patients, and that is very relevant today. आज एक वेव गेली, दुसरी वेव गेली, तिसरी येते की नाही, आली तर काय करायचं, अशा बऱ्याच गोष्टी जोपर्यंत सॉर्ट आउट होत नाही तोपर्यंत पोस्ट कोविड पेशंट आपल्याकडे येतच राहणार आणि वी हॅव टू टेक केअर ऑफ देम ऑल द टाइम. Of course, there are many terms to this particular syndrome. This is a new thing because COVID is new and the care of patients has not been formulated completely. And then you have different terms. There is no one particular definition for this particular syndrome. It is also called long COVID. It is called post-acute sequelae of SARS-CoV-2 PASC. Very big. Post-acute COVID-19, chronic COVID-19, and post-COVID syndrome. I think post-COVID syndrome is quite explanatory, is short, and we can easily connect with the patient. What patient comes to you, doctor, मला काय झालंय? You can easily say that you have a post-COVID syndrome. So what is long COVID actually? There is no fixed definition as yet. Commonly used, it is a definition, it is a term commonly used to describe signs and symptoms that continue to develop 4 weeks after the initial infection, after detection. So even after 4 weeks, generally आपण जे बघतो जे mild symptomatic or asymptomatic or even moderate symptomatic, they generally recover within 14 days. 14 days झाले की ते बाहेर पडतात, खुश होतात, आनंदाने इकडे तिकडे वावरायला लागतात. But there are certain patients who continue to develop some problem or other all the time. They come to you very frequently. They can't really describe what exactly happening to them. Today's talk is just to be ourselves to get enlightened what exactly is post-COVID, what symptoms can be there. The presence of lingering symptoms have significant impact on their lives, their livelihood, and their families. And their family मध्ये सुद्धा बरेच problem निर्माण व्हायला लागतात because one COVID patient was there all the time. This particular syndrome is not limited to elderly. It is also seen in teenagers and children who have come out of COVID. How many patients get long COVID? Well, actually, people who are in home quarantine, they generally come out very easily. But then hospitalized patients, more than 70% of hospitalized patients didn't make full recovery after 5 months of Western हे आपल्याकडे सगळं इतकं डेटा आपल्या प्रॅक्टिस वरून आपल्याला अंदाज डिस्चार्ज असं वाटतं. So about 70% of hospitalization did make full recovery after 5 months of 18% were working before could not work again. म्हणजे त्यांची जी livelihood होती ते काय जे करायचे, maybe traveling, they were salesmen, they were traveling a lot, they were doing physical exertion. Those people just could not get back to their work. 18% of the people. 35% of non-hospitalized patients continue to suffer from some or the other symptoms. So even non-hospitalized patients, you get this problem. Patients who had comorbidities, of course, they had higher incidence. Some patients develop new symptoms like hair loss or new onset diabetes sometimes, some people. Who develop? Yes. Yes, next. Who develops long COVID? It's common in patients with severe initial symptoms, but also seen with patients with mild to moderate disease. Also patients who had initially had a lot of disease. They were breathless, they were homebound, they were having needed some oxygen also. They were the symptoms which landed up into long COVID. Old age, comorbidities, higher BMI, yes, of course. Females, because generally this particular highest incidence was found in menopausal age, around the age around 40 to 50, as the incidence says that even in first wave, these were the people most affected, even the second wave, only eka varshata farak hai, 49 and 50 aside. So this is the menopausal age, and these people were in those very in an area where they have emotional disturbances, hormonal changes are keep coming up. So females have been more affected post long COVID than males. If a person had more than 5 symptoms during the first week, including nasal anosmia and high-grade fever, cough, breathlessness, hypoxia, these people landed up into long COVID more frequently. What is different from other illness as far as possible? You can see symptoms of long COVID, they persist for weeks to months. In common influenza or common pneumonitis or any other respiratory disease, we do not see patients. They come, we give medicines, they recover on their own, or we give some medicine and they recover. But at the most, it lasts for about 10 days, 15 days, 20 days. But this keeps on and on and on from weeks to months. It continues. It is mild or completely disabling. There's complete spectrum. Multiple systems are involved. I will tell you one by one. Persistent symptoms may be there, or intermittent, or relapsing. They are different. They vary from day to day. एक दिवस त्यांना चांगलं वाटतंय, आज मला छान वाटतंय डॉक्टर, बरं का? उद्या म्हणतो नाही सर, मला परत काहीतरी सुरू झालेलं आहे. मला परत दुखायला लागलेलं, पाठ दुखायला लागली, दम लागायला लागला. There can be specific triggers like physical or mental activities, stress, menses, heat, or even alcohol. I will tell you one thing. Most of these young people who have been working with IT industry, they keep on sitting for a very long time. कंपनीला माहित नसतं त्यांना काय त्रास होतोय. ते कम अप अँड ते कंपनीने तुमचं बॅकलॉग राहिला, तुम्ही हे काम करा, तुम्ही ते काम करा. इनफॅक्ट वर्क फ्रॉम होम म्हणजे शापच झालेला आहे की त्यांना जास्तच काम करायला लागतं असं ते म्हणतात. Everybody is being stressed to work more and more and be more productive. And then they keep on sitting, there is a lot of stress, they are not fit. त्यांना घरी जायची, त्यांना ताबडतोब काम करायची घाई असते. ते म्हणतात डॉक्टर मी केव्हा चालू करू, मी केव्हा चालू करू, मी केव्हा चालू करू. आपण म्हणतो थांब रे बाबा, हा साधा आजार नाहीये, थांब. पण नाही, they don't listen. They start doing that and then they land up into severe brain fog and many other symptoms that come up later on. So, physical or mental activity, suddenly they start, they get problem. There is a lot of stress of work, menses lead to exacerbation of symptoms. Even alcohol, एक काही काही लोक असे आहेत जे लोक त्यांना टँकर म्हणतात किती घातले तरी काही फरक पडत नाही पण टँकर सुद्धा पटकन फुल व्हायला लागलं असं लोकांना कळायला लागलं देर आर मेनी थिंग्स दॅट हॅव दॅट इज नो एक्सप्लेनेशन फॉर दॅट ऍक्च्युअली का असं व्हावं काही कळत नाही पण मेनी थिंग्स अल्कोहोल घेतल्यानंतर सिम्पटम्स वाढतात असं दिसून आलेलं आहे सो ऑल म्हणजे असं त्याला सांगतात नाही कशामुळे होत आहे well, so I will just one by one just tell you the symptoms, then we'll discuss it. Fatigue is the most common, shortness of breath, then hypoxia when they monitor their oxygen, because you cannot keep a person in the hospital all the time till he recovers from hypoxia. They have to be sent home because the bed availability is very small. So you have to send the people home with home monitoring and maybe oxygen concentrator, and they have to do that. So breathlessness, shortness, cough, low mood, headaches. One should also be very vigilant because a headache can represent an embolic stroke, which is very common. Coagulopathy is very common in such people. So this can come up. Brain fog, which is difficulty in concentrating. There may be cognitive impairment also. So these things are coming up. चेस्ट पेन टिपिकल लोक म्हणतात की श्वास घेतलं की भाजल्यासारखं वाटतं श्वास घेतलं की असं मोठा श्वास घेतलं की भाजलीस सिम्पटम इज क्वाइट कॉमन यू रिअली से देन ऑफकोर्स खोकल्यानंतर पण भाजल्यासारखं वाटतं दॅट इज ऑल्सो वन ऑफ द सिम्पटम्स एंझायटी डिप्रेशन rash congenital condition of course madam has just told us about how important it is to look up for conjunctival congestion and then look for mucormycosis. Then joint pains, muscle aches and pains, muscle weakness, ongoing changes of smell and taste. It may be anosmia which has come up, or there is something called parosmia. So diesel सारखा वास येतो, सडल्यासारखा वास येतो, कुठल्याही गोष्टीला. So person not able to फुलाचा वास घेतला तसं घाणेरडा वास येतो असं म्हणतात. So very difficult actually. Then a person can have palpitations at night, which can be arrhythmias precipitated by myocarditis or congestive failure or certain things. The sleep disturbances are very common. A person may not be able to fall asleep very soon, or he may get up quite early. The sleep cycle changes. Some people say, "मला इतकी झोप येते, मला इतकी प्रचंड झोप येते, मला एवढी भूक लागते, भयंकर भूक लागते कोविड मध्ये." So all sorts of combinations and things have been seen, but like except pregnancy, all the symptoms can be seen. असं दिसायला लागलंय. Pregnancy पण वाढली. All sorts of things are happening. So the COVID children असं होतं. So hair loss is seen in many people, especially ladies, menopausal, postmenopausal. They have known to have a lot of hair loss suddenly. Weight gain or weight loss. Some people they just don't find any appetite and they tend to lose weight. Some people they find a very good appetite because they're at home. त्यांना काही कामच नव्हतं त्यामुळे after a very long time they got a very big break and then started eating and ate so much that they gained weight. Then Sicca syndrome is one thing. Dryness of mouth. As you must have rheumatoid arthritis and other autoimmune diseases. You can get Sicca syndrome, dryness of mouth. Anorexia or pain in the abdomen can be a sign of gut ischemia. So there's some embolus here and there leading to that. Sweating, sudden sweating when a person gets up or even small activity or even not doing any activity, sudden sweating can come up. There can be diarrhea. Infertility is somehow coming up in the papers nowadays. There may be many other reasons for this. Recurrent fever is also one thing. The patient comes up. डॉक्टर मला घरी आलो माझा कोरा बरा झाला मी निगेटिव्ह आलो पण मला ताप येतोय मला परत इन्फेक्शन झालंय का सो वी हॅव टू रियली इन्व्हेस्टिगेट काय कशामुळे ताप आला कशामुळे काय होतंय दॅट हॅज टू बी फाउंड आउट अ न्यू ऑनसेट डायबिटीज और वर्सनिंग ऑफ प्रेझेंट डायबिटीज इज वन थिंग because the hospital patient must have received a steroid or there is a lot of physical and mental stress. mental stress is very, very important. Even home quarantine people, they think that I'm gone. They read so much of newspapers. In the news, everything is about corona. When there are hundreds and thousands of relatives who give them hundreds and thousands of inputs. की तुला असं आहे का, तुला तसं झालंय का? So everything adds up to the stress, and a person who is quite sensitive can become mad actually. So I will just take up this fatigue, which is the most common symptom. The tiredness, it is basically tiredness while performing daily physical activities. डॉक्टर मला काही करावंसंच वाटत नाही. मी उठलो तिकडे गेलो काही करायला लागलो. स्वयंपाक करायचं म्हटलं तरी मला अजिबात जमत नाही. मला काही करावंसंच वाटत नाही. फटीग वाटतं, नुसतं झोपून राहावंसारखं वाटतं. So these are very typical things. Unable to start routine exercises, especially ladies. स्वयंपाक करायचं म्हणजे संकट आहे. म्हणजे संकट, of course it is there, but then त्याच्यामध्ये जरा मोठं संकट वाटतं. There is there's a reason also. So that fatigue is very, very difficult to then. There is some explanation for this. There is some immunological cause, some mast cell activation. Many researches, lot of research is going on in this particular field, but then the answers are still awaited. Myocarditis can be one thing which keeps on a very low scale and leads to fatigue. Even small activity can lead to breathlessness. A person would have to lie down for a while after just walking about here and there. Then, of course, the treatment can be gradually graded exercise. Some people have tried so many things. Everybody, in fact, everybody must have tried all sorts of things. Some things work, some don't. Some people give Q, coenzyme Q, ginseng. Of course, one should also look up for lab for anemia in such, especially fatigue, because these people are routinely prescribed aspirin. Aspirin, anticoagulants are on a person who is having small gut hemorrhage, small ulcer, or any other problem can lead to blood loss in the GIT and develop anemia suddenly or maybe over a period of time. So all the patients are on aspirin for this particular disease. So they tend to develop this problem. When you have shortness of breath and cough, they should be properly investigated. It persists in patients who are hospitalized and who need oxygen. That is natural. But then even during recovery, these things come up and the patient doesn't feel well at all. One should, of course, rule out pulmonary or fresh pulmonary embolism because these people, especially the IT people, they sit for a very, very long time in one particular place. They work for 12 hours, 13, 14 hours. They tell, working for such a long, just don't get up from one. So pulmonary embolism, they develop DVT because this particular disease, COVID, has a typical tendency of producing clots. That is the basic pathology in COVID. That's how it is different from most of the other diseases. And in people who were just sitting for a long time, they tend to develop DVT, and then they start walking suddenly. This dislodges and lead to pulmonary embolism, sudden onset dyspnea, myocarditis, arrhythmias. A person may not realize he's on home quarantine, he has recovered, and feels dyspneic all the time. Walking here and there and starts producing the breathlessness, then you can have arrhythmias. Secondary infection has to be sought because he has received a lot of steroids, diabetes, is uncontrolled, and can develop secondary infection, bacterial pneumonia. There may be anemia or there may be CCL. All these have to be evaluated accordingly, get an echo done and find out. You should monitor, in such cases, better to monitor D-dimer. This can last for a very long time and people just keep on troubling you, Dr. Mikai, Dr. Mikai. You can do nothing, you can just tell them that it will subside, your body will take care of itself in a matter of time and you will come out of it. Don't keep on monitoring D-dimer all the time. Maybe if it is very high, you can add some anticoagulants for a while and then keep a watch and whether it comes down or not. Oral anticoagulants are quite useful, rivaroxaban and all. It helps very well. Please. 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 Home oxygen monitoring is one thing which is, of course, you should D-dimer, TLC, CRP, echo, and X-ray should be done to rule out all these things and accordingly treat that way. Home monitoring of oxygen is one thing is described as 6 minutes walk. But how should you do that? One should first remove the nail polish from the nails, then put the oxygen pulse ox meter and walk rapidly. म्हणजे दम लागेल असं फास्ट चालायला पाहिजे 6 मिनिटं. इट इज नॉट इझी फॉर अ पर्सन जर अगदी अगदी आरामात रमत गमत चालून चालून केलं तर 6 मिनिट्स वॉकचा काही अर्थ नाहीये. सो यू शुड वॉक व्हेरी फास्ट. दम लागेपर्यंत फास्ट वॉक करा. त्याच्यानंतर पण तुम्ही चेक करा. दॅट इज मोर इन्फॉर्मेटिव्ह rather than just casual walking. A person should be asked to sleep prone because that helps in the ICU also, in the wards also, and home. A person who is breathless, who gets hypoxic, should be encouraged to sleep at least 12 hours a day on his face. He should be made to do that. Oxygen supplement as required. Graduated exercise protocol is one thing which is also required. You can just tell him, increase your walking time by 10 minutes every week till you achieve your full fitness. Then nebulization steam will also help. And of course, watch for mucor if a person still has breathlessness and cough. So mucor doesn't leave you. It is not in the sinuses, it will come to the lungs. Chest pain, it can be pleuritic by deep inspiration. It can be like angina because angina, a person who's very well goes home from hospital, waits for a while, and suddenly comes with a myocardial infarction or stroke. Again, because of embolic, this particular disease has that particular problem. So embolic stroke can, or angina can be, or infarct can be there. A lung burn, because a person when he breathes in deeply, he gets that particular severe chest pain that comes up. It can be a radicular pain or it can be diabetic neuropathy because of recent worsening of diabetes because of steroids. So this can be a big problem. Of course, you can just get his X-ray chest, ECG, check up his B12, B3 levels. I think B3 will be very high. Everybody is taking B3 now. Then, of course, monitor his blood sugar. Can just give him NSAIDs, local applications, or proton pump inhibitors, and that will help. A breathing technique should be, I think, you must have prescribed to your patients also. Deep breathing, slow, deep breathing, and slow exhalations. They keep very good, they help the patients very well, and they generally come out of this problem gradually. They feel better. Sudden short breaths, they increase the chest pain and things. So gradual, simple breathing itself will definitely help. Neuropsychiatric symptoms are of course there. A headache, if it is there, one should always rule out a stroke. A mucor, it can be a tension headache, especially who are sensitive people and who have been exposed to this particular stress of home isolation is very difficult. Another thing that very common actually, when a virus enters home, it infects everybody in the family. And if there is only husband and wife, and if they're isolated for 15 days, tension headache, everybody will get it. The low mood is there, anxiety, depression, another thing. Another thing is post-traumatic stress disorder. This was seen first in natural calamities like earthquakes, floods, or in war, or when people were suddenly exposed to severe stress, and that led to loss of sleep that reflected on their later life. And so that's how it happens even in these cases also, because the hype about the corona is such high that people are very, very afraid. When isolated, they feel they probably not see anybody now, they will be directly going up. But then that particular stress has after effects. There are certain people, even after 6-7 months, I have a lady who keeps coming with abdominal pain and breathlessness. She has nothing. All the things have been excluded. Still, she has this particular problem. She's not coming out of it. A brain fog is one thing which indicates, which is inability to concentrate on particular problem, blanking out. If a person was working, especially IT people or anybody, if he's working on one particular job and he was able to complete in 1 hour, he is now taking 2 hours, 3 hours for completing the same job. The efficiency of thinking, of applying your mind becomes less. the concentrating power or maybe the span of concentration becomes less and less. That's something that comes up. Blanking out sometimes. You don't realize मी काय काय करत होतो, काय कुठे ठेवलं ते लक्षात राहत नाही. And so these things have memory losses, they come up. Sleep disturbances are there, strokes, mostly embolic, palsies, they come up mostly embolic. Some people have developed Guillain-Barré syndrome, but which is quite rare, but it has developed. There was a post, Dr. Sadarji होते अपने जो भी होते हाँ Dasmeet Singh. He developed Guillain-Barré syndrome. He came out of it very well, thank God. Disturbance of taste and smell. It represents involvement of olfactory nerve endings. The surrounding soft tissues swollen up. It may recover early, but sometimes some people have for a very long time. There may be specific loss of smell to one particular thing. Maybe flowers, or person cannot smell flowers at all. He may start masala वास कुठे यायला लागते, चव लागायला लागते, but फुलांचा वास येत नाही. Some people develop parosmia. They have rotten smell for everything. जेवायला बसले rotten smell. डिझेलचा वास येतोय मला सगळीकडनं. किंवा मला बर्निंग काहीतरी जळतंय, बाजारासारखं वाटतंय, जळल्याचा वास येतो सगळीकडनं. That sort of parosmias, again, it is because of affection of olfactory nerve endings. Then they have some ways of quantifying it by doing sniffing sticks test. A set of strong smelling natural oils are given and person is asked to identify that over a period of time. ते हळूहळू करून जमतं. But then if a person has anosmia, you can just ask him to sniff different sets of oils, say eucalyptus oil or हिंगाचा वास, strong जे perfume असतात किंवा असं वास 4 प्रकारचे वास 10 मिनिटं श्वास घ्यायचा, सकाळी घ्यायचा आणि संध्याकाळी घ्यायचा. सो 2 वेळा घेतलं तर हळूहळू करून जे काय होईल ते करून नॉर्मल स्टिम्युलेट करून थोडा इम्प्रुव्हमेंट हळूहळू व्हायला लागते. अशी कुठे स्टडीज झालेले आहेत. You'll see that. Skin manifestations are there. A rash may be localized, it may be urticarial, it may be macular, it may be papular, it may be embolic. आपण जे आपल्याला purpura सापडतो, palpable purpura. Even all those things can also be seen with COVID. That this can be thromboembolic, as I said. It may be transient and local application antihistaminics may go away, but it may relieve it completely. Conjunctival condition can be because of allergy to viral component. Topical iodine, as Madam has suggested, can use that. Hair loss is unexplained, whether it is because of stress or because of something else. It's very difficult to say. Sweating disturbances can be autonomic neuropathy. It can be a cardiac manifestation also, especially diabetic who have autonomic neuropathy. They can get a painless infarct. They can be angina, which can just come up as sweating. People who have just increased their diabetes because of steroids can have these symptoms without any complications or any other symptoms of angina or infarct. The COVID toes have been seen in certain people, which is another embolic phenomena where you can see the toes becoming having a reddish hue to the toes. It's not seen in Indian population, but it's seen in Western population. Favipiravir, which was used, in fact, even used today for treatment of COVID, also produces blue toes of nails sometimes. Musculoskeletal problems, joint pains is part of debility, which person takes complete rest for 15 days and suddenly starts walking about. Or in patients who were hospitalized for quite some time and now they have come up with hyperglycemia and diabetes, and that leads to myopathy. Favipiravir itself can lead to hyperuricemia. So when your person is on favipiravir, one should always check up his uric acid levels, and they can be it can go very high and it can precipitate count and lead to joint pains and inflammation. Too much rest followed by sudden activity. लोक तसे थांबले असतात 15 दिवस केव्हा समजणार मी केव्हा बाहेर पडतो आणि पडतो म्हणजे जे सुटतात एकदम सुटूनच जातात. They start walking, they think they are absolutely fine. They ultimately land up into trouble later on. But then certain activity, certain muscular exercises can lead to severe pain in joints, and because the joints are not sudden activity. Long-term steroid use can lead to necrosis of head of femur. This is one a very, very important one. Just as mucor is a late complication of steroid and hyperglycemia, similarly, a steroid can also lead to necrosis of head of femur and lead to severe pain in the hip joint. Of course, uncontrolled diabetes also promotes weakness and debility. Gastrointestinal Sitka syndrome is dryness of mouth. It is reduced because of reduced salivation. A sips of water or some spray like the saliva or something can help. Pain in the abdomen can be a gut ischemia due to thrombi, phrenic infarcts, or pancreatitis can be there. Diarrhea is again can be because of segmental gut ischemia, prolonged antibiotics leading to superadded infection of fungal candidiasis, which can come up sometimes, malabsorption because of the prolonged antibiotic use, and anxiety also can lead to diarrhea. So we can gradually one by one rule these out and treat him. Anorexia can be gut problem, ischemic, or it can gradually anxiety can also lead to this. It will reduce gradually. Investigate, see the lab, get us ultrasound done, or CT angio to find out any infarcts or not. You can find endocrine dysfunction. New onset diabetes, a person who has not been diabetic for a very long any time, and he has not received steroids, also they tend to develop new onset diabetes. So this is one thing which has come up. Can be steroid stress or pancreatic involvement of the by the COVID virus. It may be temporary or it may be permanent. Temporary, when they reduce steroid, it comes down, but if not, then we have to treat it accordingly. Worsening of diabetes may require increase in doses of insulin and those precautions. Infertility has been reported because of stress, lack of exercise, drugs, and diabetes. So all these can lead to infertility. Cardiovascular can have palpitations, arrhythmias, postural hypotension because of autonomic neuropathy and weakness. Orthopnea, while lying down, you get breathless suddenly. You have to cannot lie down. That has seen in congestive cardiac failure. You can have myocarditis, you can have pericarditis. So all sorts of cardiac complications can be seen. Persistent fever is one thing which bothers everybody, and it is very common. Usually to autoimmune response to viral components. So it keeps on coming and going, and going. It can be daily, intermittent, mild, or very hectic. Suddenly, 103, 104, so that you have to do it accordingly. It can be, of course, secondary to bacterial infection. Patient lying down very long time, he was catheterized, persistent urine tract infection, or superadded infection on top of his CT score of 14, 15, he can develop a superadded infection, bacterial infection also. Fungal infection is also common. There can be pulmonary embolism, can be UTI due to catheterization. You can treat it symptomatically if the appetite is preserved. One underlying thing, if the appetite is good, you don't worry. But if the appetite is also falling down, you should always find out the reason, whether there is really sepsis or not, do cultures and treat according to the culture report. We check up CRP, D-dimer, and imaging if required. Find out that way. There are young people who are runners. There are many people here also who run actually. And they are very eagerly waiting to start running as soon as possible. So when to resume exercise? They say, आज माझा 15 दिवस में running केव्हा सुरू करू शकतो? Patients who require oxygen during hospitalization should gradually build up exercise schedule for about 1 month before taking up heavy cardiovascular exercise. That is very, very important. That 1 month should be given for all our systems to normalize. The autoimmune system, the cardiovascular system, the hemopoietic system, everything needs some time from come out of this insult, and it has to be gradual. Patients with persistent fibrosis of lungs can be given pirfenidone or nintedanib is being used as alternative agent. Spirometric exercises are also helpful, and breathing exercises are also very helpful. So to these people. Long-term anticoagulation. Patients with massive pulmonary embolism should receive rivaroxaban 10 mg OD for up to 3 months post-discharge. Routine use of anticoagulant as prophylaxis is not recommended. One should not do that. Use of aspirin post-COVID is also unclear. It is not really well known at the moment. It is not recommended to give aspirin for a long time. Another very important thing is what is the role of vaccine in post-COVID. This one thing is very actually funny. Vaccination helps in recovery from post-COVID symptoms in many cases. This one thing is another thing that you can ask the patients to have vaccine, because if a person has post-COVID syndrome, he has fatigue, he has anosmia, not able to smell properly, if he has musculoskeletal pain, all these symptoms after vaccination tends to become less in intensity and they start recovering. So this one thing should be kept in mind, which helps. Fatigue, myalgia, and olfaction has been reported to improve in certain cases gradually with vaccine. The exact mechanism is difficult to say. At present, it's recommended only after 3 months after recovery. So for 3 months, the patient has to suffer. So in summary, post-COVID syndrome is a definite new entity. It involves the whole body. Close monitoring of patient is required. Patients recover eventually. Support of family physician is most important. So these are the very important points out of this. Thank you very much for your patient question. Thank you.
Thank you very much, sir, for this enlightening lecture. Sir has covered all the systems in the body. Sir, sir has covered all the systems in the body and also highlighted how we should progress for the post-COVID exercises and the role of vaccine in post-COVID patients. Thanks again, sir. Anyone, any questions?
One question. Post-vaccination complications could be unlikely.
So, but the incidence is quite low actually. Can get embolism. Some people, माझ्याकडे काही cases अशा होत्या. A patient who had superior venous sinus thrombosis of the brain. She was there for a very long time, taking rivaroxaban and others for a long time. She discontinued it for past 6 months. And then she asked me whether should I take vaccine. I said, yes, you may go ahead and take the vaccine. She took the vaccine. On 5th day, she developed thrombosis again. So there are many things which come up actually, but then overall, the use of vaccine is very, very important. It helps in many ways.
Aspirin for how many days?
The aspirin,
Coming down. D-dimer is not coming down. Aspirin for how many days?
we don't give aspirin. But it is not recommended at all for giving aspirin for a long time. And there is not much of a use of aspirin.
Thank you. Once again, sir.
Thank you very much.
Thank you very much, sir. It's always a treat to hear from you. So thank you very much. And thank you today's chairperson, Dr. Prerna Barve and Dr. Rajesh Doshi. I request GPA President Dr. Shivaji Kole to kindly felicitate Sudhir Mule, sir. Thank you, sir. I request Dr. Kole, sir, to felicitate Dr. Rajesh Doshi. Dr. Prerna Barve. Thank you all. Thank you very much. Moving towards our last academic session by Dr. Amol Deshpande. To chair this session, I invite Dr. Mangesh Wagh and Dr. Satyesh Kothade on dais. Dr. Mangesh Wagh is BMS and practicing at Hadapsar since last 22 years. He is the owner of Shatayu Nursing Home. He is the director of Noble Samruddhi Diagnostic Center. He is the president of Hadapsar Congress Doctor Cell. He is ex-president of HDA and MHRDA. Our second chairperson, Dr. Satyesh Kothawade, is a BHMS, PGDEMS, practicing at Bowden since last 12 years. He is a past president of WPDA. Over to you, Dr. Mangeshwar.
Welcome, Dr. Amar Deshpande, sir. Amar Deshpande, sir, the MSc PJ Medical College and Sassoon Hospital, Delhi line. Amar Deshpande, sir, MS मध्ये पुणे युनिव्हर्सिटी मध्ये फर्स्ट आलेले आहेत. Deshpande, sir, practicing as a consultant ENT endoscopic sinus surgeon since 14 years. That's only by Central ENT Hospital Wadi. The partner and consultant at Shashwat Hospital, Kothur. Consultant ENT surgeon at Pune Hospital also. Special interest in micro-EM surgery and endoscopic sinus and skull-based surgery. I request Dr. Deshpande, sir, to continue.
Thank you. I would like to thank you especially to General Practitioners Association and also Dr. Mundesar Shashwat Hospital to give me this opportunity to talk and share my experience with post-COVID mucormycosis with you. Before that, I want to thank and congratulate all these practitioners and physicians for fighting this COVID infection pandemic selflessly and sincerely. Thanks a lot. So coming to this mucormycosis, this is a really dreaded and fearful infection we have encountered for the past few months or maybe over a year after COVID. Is it a new infection? No, it is not a new infection. We have been seeing mucormycosis cases before, but there were very few. The incidence was very few, very less, and many of us may not have seen a mucormycosis case in the practice in the general practice, maybe because it is seen in an uncontrolled COVID situation. So what is mucormycosis in general? It's not a new disease, it's a fungus. The spores can be seen as a normal commensal everywhere. It is ubiquitous to our surroundings. It is present here in this desk, on our mobiles, in the laptops, on chairs and tables, everywhere. But it does not cause infection in an immunocompetent or normal person. So which organisms are producing this mucormycosis? It's a fungus. It's a class of zygomycetes. Generally, it can be divided into three classes. The most common is the mucorales. This fungi from this mucorales order, which cause the disease in the human beings, is called mucormycosis. The most common of that mucorales is the rhizopus, mucor, and other three, four fungi. But most common is the rhizopus, which the media has called a black fungus, which itself is not a black, but which causes the necrosis, which is seen as a black. So it has got the name of black fungus. Previous to the COVID, we have been seeing this mucormycosis in the patients with the uncontrolled diabetic mellitus, diabetes mellitus with ketoacidosis patients. We are seeing these patients in other forms of metabolic acidosis conditions, which patients treated in ICU for different types of diseases with acidosis, especially in the patients who have been treated with the high doses of corticosteroids for a longer period of time. Those patients used to show the mucormycosis infection. Few persons with an organ, which are where organ transplantees, bone marrow transplantation, in which we have to give immunosuppressive agents for a long term. In those patients, we saw mucormycosis. In patients with neutropenia, in a few patients with a malignant hematological disorders, and with some disorders where a free iron was present in the serum compared to the other patients, because this iron is a food for this fungus. When free iron is present in the blood, the mucor thrives upon it. So why the COVID-19 has created this surge of mucormycosis? The COVID-19 in itself is an immunosuppressive tendency, immunosuppressive state. It causes T cell dysfunction. It causes destruction of T cell. We see a lymphopenia, a reduced CD4 and CD8 count in COVID-19 patients. Due to this T cell damages, and there is release of cytokines. There is inflammatory cytokine surge in COVID-19 patients. And the interleukin 6, ferritin, and all these cytokines ultimately they damage endothelial cells of the blood vessels, the inner lining of the blood vessels. This is called endotheliolitis. This direct viral infection of the endothelial cells damage the inner lining of the vessels, and diffuse inflammation of these vessels itself creates a prothrombotic state. So that this patient is particularly predisposed to form a thrombotic phenomenon. So we are seeing myocardial infarcts, then brain infarcts in these patients afterward also. So this COVID-19 is causing this. And COVID-19 is found to directly affect the beta cells of the pancreas. So it causes a newly diabetic condition, diabetogenic state in this patient. The patients were not previously diabetic, but after they get an infection, then we are seeing the hyperglycemia in those patients. So this is newly developed diabetes, we can say, because of the COVID-19. And here comes the association of a diabetes and mucormycosis. Diabetes causes impaired neutrophil function. It affects the chemostasis, the migration, transmembrane migration of the T lymphocytes. It reduces specifically this COVID-19 and diabetes. They reduce the binding of iron to the transferrin protein. This transfer is important to transport the iron to the tissues. When this transferrin binding is affected, the free iron is present for the fungus to grow in this acidotic condition of diabetes. There is an increased representation of glucose-related protein 78, GRP78, in the endothelial cells of these diabetic patients. And this GRP78 is definitely the mucor has an affinity toward this receptor, GRP78. And these mucormycosis spores, they get attached to these endothelial cells, which increasingly express the GRP78, and they damage the endothelial cells. So even the platelet dysfunction is found because of the diabetes. So all this scenario is favorable for mucormycosis to grow upon. And next stage, the most important factor now we are seeing is the steroids. We have been treating COVID-19 for the first time. N number of treatments have been postulated. We are giving antiviral, we are giving antibacterial, we are giving anti-helminthic, zinc, iron, whatnot, vitamin C, everything. But the only proven treatment which have given a benefit to us is oxygen and a steroid. That's true. But steroid comes in the picture when cytokine is there. The first few days of a viremia, replication of a virus, steroid is not indicated. Rather, it is a detrimental. But there is so much pressure upon us from our relatives, our VIP patients, and they know somewhere from the other, steroid is working, steroid is working. So there is a demand from patient itself. Then we are in the fix. So general practitioners, physicians, we are also, when our relative or VIP patient says, then we are tending to give a steroid or but this is not going to prevent cytokine surge. It is not indicated. That we have to keep in mind. This steroid is causing hyperglycemia itself. So COVID-19 is affecting pancreas. Steroid is giving hyperglycemia, and this is a deadly combination for mucormycosis. Second thing, steroid is causing impaired function of neutrophils, which everybody will know. It causes immunosuppression. So steroid has to be avoided in mild cases. Steroid has to be avoided in home quarantine patients. Steroid has to be avoided on OPD basis. Steroid has to be avoided in the patients who are not having severe symptoms. So which are the patients who have high risk of COVID-19 for mucor? Patients who are having lymphopenia on the laboratory reports. Those patients who have been treated for high dose of steroids because of the severity of symptoms in the ICU setup. Patients which typically show high levels of interleukin 6 and ferritin. Patients who had to be given tocilizumab for their severe symptoms or other immunomodulators. Patients are showing neutropenia. Known patients with uncontrolled diabetes which turn up with the COVID-19. These are high-risk COVID-19 patients which can develop mucormycosis, and prolonged use of broad-spectrum antibiotics for any other associated infection with the COVID. These are the predisposing or high-risk patients for developing mucormycosis. So these are the patients which you should be vigilant. You have to advise nasal endoscopy repeated. You have to look for early symptoms of mucormycosis in these patients. You have to ask the patient about these symptoms. What are the early symptoms? Excessive dryness in the nose is the earliest symptom. There is formation of scabs, which patients cannot take it out. They feel the dryness in the nose, and there could be a blackish discharge from the nose. But one consistent symptom, which I have seen from my residency also in my practice also, which is hampered on me by my teachers also, that we can see even in practice. Most common first symptom is the numbness over and around the nose, over the cheek area, because this is the main area which is affected by mucor. The cheekbone, the maxillary bone, the area behind the maxillary bone, where it starts, the necrosis starts. The nerves coming to the cheek, they have the root behind the maxilla, pericopalatine fossa. And when first there is a necrosis, this sensation goes. From there, the infection goes to orbit. It goes to orbital apex, it goes to intracranial. But the first early symptom is dryness of nasal mucosa and numbness, paresthesia over the cheek. This patient may not present himself with that. You have to ask for it. When the eyeball gets proptosis, red, then it is obvious. The numbness is easily forgettable with the patient. So you have that. This is very specific symptom is there. Then in the advanced stages, there may be a loosening of teeth because of osteomyelitis and necrosis of the palate. There could be a difficulty in biting. And when it spreads, it's obviously black discoloration of cheek, nose, palate, proptosis and all. So this is one slide showing early scab formation, early necrosis of the middle terminate. As madam and sir also told, that middle terminate nose is the first thing to get affected. But this is not easily seen on, may not be easily seen on for a general practitioner to see. But if you send this patient to nasal endoscopy in early stages, we can find this early scab formation and we can start the treatment early. Later, this is a full-blown disease. You can see all necros mucosa is black ischias. From where the fungus got his name, black fungus. It's all necros, material in the nose, all the terminates, everything has gone completely necros with the pus. So this is mucormycosis. We have to remove all this dead tissue because the treatment of this disease is actually antifungal, amphotericin B. But antifungal, to reach this area, the area has to have a blood supply. If the necrous tissue is not going to have that antifungal to reach there, so we need to debride all these things. We have to remove the necrotic material till we get a good bleeding mucosa, and then the antifungal will act. The main treatment is antifungal, but for that, to reach the antifungal there, we need to excise, debride all this dead tissue. This is also one of the early presentation of the palatal involvement. See, this is the swollen gums, swellings in the gums at the root of the teeth shows the early involvement osteomyelitis of the palate. The dentist can get this symptom early, but even we or general practitioners can assess for this. This is typical pustule showing in the gums. This is the necros, alveolus, maxilla, And in the late stages, we have to remove that. These are the very late presentations of the disease. This is palatal necrosis, complete. This is the skin also necrosis. See, this is the typical area below the nose, around the forehead and the. See here also. This is all necrosis, and in these cases, we have to remove all this tissue, all maxilla, skin, and all. So it is very dreadful, very dangerous, very depressive to the patient. So what we can do for the diagnosis of the patient, early diagnosis, nasal endoscopy, serial nasal endoscopy, especially in high risk patients, we should advise to ENT consultation and radiological investigations. There is a common propensity to do a CT scan of PNS. We know CT scan for sinusitis and all, but for mucor, CT scan for diagnosis of mucormycosis, CT scan is no role. CT scan shows bony destruction and all afterwards. For diagnosis, CT scan is not the investigation. Contrast enhanced MRI is the investigation of choice for mucormycosis because the MRI distinguishes between a normal sinusitis and a mucormycosis, a necrosed tissue, and a fungal element in the tissue, which CT scan cannot describe. And afterwards, if we send a biopsy or a frozen section or histopad, will show the fungus in the tissue. No blood test can diagnose a mucormycosis. This is also an endoscopy picture with early pickup. The anteriorly mucosa is good, well pink. When you see posteriorly, see pale white mucosa. It's all pale and it will necrose in a few days. So this is early pickup with the endoscopy. This is late presentation. See all necrose, pus, necrotic material. This is all dead tissue. All has to be debrided, excised completely for the complete treatment of this fungus. This patient came with a complaint of bilateral ptosis, drooping of eyelids, left ear, left eye, complete vision loss. Otherwise, the patient did not have any complaints. Sudden vision loss of left side, bilateral ptosis. On endoscopy, the MRI did not show much of the disease anywhere in the sinuses, just a little bit necrosis on the anterior end of terminate of the left side. But the MRI picked it up. On endoscopy, while surgery, we could see only this small black scab on the terminate. That's it. But in particular, this patient, that vision loss could be because of the central retinal artery occlusion, because of thromboembolic phenomenon, because of mucor, or maybe of COVID itself. But these patients could be picked up with the MRI early and endoscopy. See, this is a CT scan picture. This edematous tissue can be of a normal sinusitis, can be of just a allergic sinusitis also. If we do a CT scans of these people present here, 10 will show this kind of edema. This is not a mucor. Mucor will be diagnosed only on MRI. Don't do CTPNS. This is typical black turbinate site, which madam has told. See how we distinguish mucor from MRI. This is a contrast enhanced MRI showing this enhanced tissue. This is an inflammatory tissue. Routine inflammation, infection. The blood is reaching this area, is enhanced inflammation. It's okay. You don't have to remove this. This is not a mucormycosis. This is a sinusitis. This is ischemic area, which is not enhancing. This is ischemic area. This is non-enhancing. It has to go because the amphotericin will not reach this area because this doesn't have a blood supply. So this is distinguishing factor. This we have to remove. I will not touch this sinus because this is not necrotic. This is not fungus. This is a diffusion weighted MRI. These will also show early signs before a symptom appears. Here, enhancement of optic nerve. Here you can see a ischemia in the temporal lobe. So this early ischemia can be picked up in the diffusion weighted MRI before even the symptoms arrive. This is the histopathology slide. showing the fungus, which madam has also showed, accepted fungi straight. So what are the medical treatment, which is the main line of treatment? Shortly, is the antifungal drug, amphotericin B. There are different types of amphotericin B available. Liposomal is the best because it has a less adverse effects on kidney, but it is too costly. In by the COVID itself, patient has lost a lot of money in the treatment. On the top of that, when you tell them की आता तुला fungus झालेला आहे and you have to spend 7 and 10 lakh rupees now, त्याची family पूर्ण devastate होते. Very difficult to spend 8, 9, 10 lakh rupees after going through the COVID. So it is very depressing. So we have to take economic condition of the patients in the mind also. If he has a good kidney function, we can advise simple amphotericin also, keeping in mind creatinine levels. There is also isavuconazole, posaconazole. Isavuconazole is more costlier than this amphotericin B. Posaconazole tablets in patients we have recovered after amphotericin, we can shift them on a posaconazole. So what development we are seeing over the period in the treatment of mucormycosis? As madam also showed that statistics are also told. Before these recent times, the mortality of this mucormycosis was more than 40%, 50%, 60%, because there was not advanced endoscopic debridement procedures. We could not see directly up to what we have to remove. With the advance of MRI, which give you direct evidence of what has to be removed, what has not to be removed. We can go endoscopically, remove that much area. If eye is involved, every patient we don't have to remove eyeball. Only that part of the eye which shows a fungus, we can do a limited debridement of that. So the patient can, the eye can be saved. Removing an eye is a very depressive thing. Patient gets completely depressed. He doesn't want to live. Madam will agree with me. Even many ophthalmologists will also not like to operate to remove the eyeball. They try to, as far as possible, save the eyeball. So with this endoscopic approach, with early diagnosis, we can save his disfigurement also. And with the wide debridement in the first sitting only, with the amphotericin B, the mortality has definitely got reduced. With the extensive debridement, the amphotericin B requirement also can be reduced. Previously, it was a dictum that 25 days, 40 days, amphotericin has to be given. It is not that the case. Extensive debridement, with serial endoscopy, with maybe repeat MRI, we can keep a watch. And when the healthy signs are showing, the cavity is good, well healthy, we can reduce the dose of amphotericin. We can reduce the dosage of amphotericin. The last patient, the latest patient which I operated in Shashwat, unfortunately, he could not get amphotericin from anywhere, from government sources, private sources, black market, whatever. So it was stressful for me because I operated, but I can't leave him like that. We started him on posaconazole. For 8 days, he was on posaconazole. We did extensive debridement in the first sitting only. After 8 days, I requested him to manage amphotericin B at some government hospital out. I told him, go there, take amphotericin for a few days. He went there for 1 week amphotericin only. Then again we shifted to posaconazole. He's doing well. So it's not a give for 40 days amphotericin. With extensive debridement, with a proper follow-up, we can reduce the amphotericin dose. We can save his money. We can save the life. So what is the role of surgery in mucormycosis? To remove the devitalized necrosed tissue, debulking of the infected tissue, which theoretically allows the faster action of antifungals against a small burden of fungi, and to establish the histopathology. See, what I was telling you, we saved this patient eye cosmetically. He had lost his vision, but to save the disfigurement, we have removed all the other things, the muscle, necrosed muscle, fat in the orbit, saving the globe and the optic nerve. So at least maybe for after a few days the eyeball will sink a bit, but there will not be a total eyeball socket, an empty socket on the face. This is the maxilla. Well, one side of maxilla removed. Just imagine the ply of the patient which has lost both of his maxillae. There's no maxilla in the jaw. It's very depressive and very dysfunctional. Here one patient. This is the orbit from the nose. These are the orbital muscles, and we removed the fungal elements which we could see on the MRI. That only we removed and preserved the rest of the eyeball. So this we can achieve with the endoscopic approach. So over the period, the treatment is developed, the mortality has definitely gone down, and we are trying to reduce the morbidity also. Thank you.
सर तुम्ही खूप साध्या सरळ सोप्या भाषेमध्ये आजचा हा उत्कंठावर्धक विषय संपवलाय.
Thank you.
आमच्या मनात खूप प्रश्न आहेत. माझ्या मते श्रोत्यांकडे ऐकायचे काही प्रश्न असतील तर प्लीज विचारू शकता.
I support from microsis. 2 months have passed and recovered well.
Great.
But I want to know, I didn't have sugar before. But as you said, I was admitted for corona and then I got very high sugar.
Yeah.
So now also I'm taking insulin. So
Yeah.
how many days is this diabetic? It's okay, tablet.
That question goes to physician. He's a better person. Yeah.
Taking insulin and
But treating hyperglycemia is not my expertise. Yeah. So I'm an ENT surgeon. So to remove what, to operate on mucormycosis is my job. To tell about sugar management is a physician's job. Before, yeah. Sir will give you that. Before that, I just want to put one comment. I want to congratulate Shashwat team who treated COVID-19, because I have not seen a single patient who has been treated for COVID-19 in Shashwat who has turned up as mucormycosis. Not a single patient. All cases where I am operated in a Shashwat or St. John were all referred to me from outside, or I went outside to operate. But not a single patient from Shashwat came to me and would turn out to be a mucor and I had to operate. Not a single. So it is a judicial management of steroid which has taken place in the Shashwat. Thank you.
धन्यवाद सर. अनेक प्रश्न आहेत पण सर आता लंच मध्ये ते विचारतील तुम्हाला बाकी लोक. पण थँक्यू सर, मी तुमचा मनापासून आभार मानतो. तुम्ही म्युकोरमायकोसिसचा हा जो विषय होता आम्हाला खूप साध्या सरळ आणि सोप्या भाषेत समजवला. आमच्या मनात खूप डाऊट्स होते. तरी पेशंट तुम्ही जे ड्रायनेस ऑफ नोज आणि नमनेस इन चीक हा विषय सांगितला, त्यात जरी आम्ही एखादा पेशंट वेळ तुमच्याकडे रेफर करू शकलो तर कदाचित त्या पेशंटचा लाईफ आणि खर्च खूप वाचेल. मी तुमचा मनापासून सगळ्यांपासून आभार मानते.
Fungus is everywhere. फंगसला इन्फेक्ट करायला, तिथं राहायला, थांबायला, it will take time. Nasal sprays, nasal washes will remove that fungus. त्याला वेळ देणार नाही तिथं राहून इन्फेक्ट करायला. फेवरेबल एन्व्हायरमेंट मे बी असेल, डायबिटीज असेल, पण फ्रिक्वेंट वॉशेस विल डेफिनेटली few percent will avoid this infection. Saline nasal sprays, not nasomys drops वगैरे. तर आयसोलेट nasal sprays, सोल स्प्रे सारखे स्प्रेज आहेत. त्या भरपूर वापरायला सांगायचं. Each and every patient कोविडचा it will help. Definitely it helps. Thank you. Mucormycosis, no.
Yes, Manoj sir.
Yeah, there was a question, madam, that if a new onset diabetes after COVID and she's taking insulin, how to control that and whether she will be able to stop insulin or not. Yes, of course, but we have to check your C-peptide levels, whether you have developed any autoimmune diabetes into that or not, whether you have developed type 1 or not. If it is just pancreatitis leading to some damage here and there, it will recover over a period of time and maybe wait for 6 months or so. and follow the diet precautions and regular exercise and weight loss. And it will definitely help you out over a period of time, and you can reduce the insulin and start oral anti-hypoglycemic agents.
Thank you,
बरोबर
sir.
सिग्नल दिलाय तर आपण इथंच थांबूया. Over to you, ma'am.
Yes, thank you, sir. Now I request GPA President Dr. Shivaji Kollar to kindly felicitate our speaker, Dr. Amol Deshpande. Thank you, sir. I request GPA President Dr. Shivaji Kollar to felicitate our chairperson, Dr. Mangesh Wag. Dr. Satej Kothawade. Thank you, all of you. Thank you very much. Friends, इथं आपलं academic session संपलेलं आहे. I request all of you to wait in hall only. We need 5 to 10 minutes for the stage arrangement for the next Doctor's Day celebration event. Thank you. I request all of you to be remaining in hall only. We are starting with our program within next 5 minutes. Please be seated. I request all of you to please be seated in hall. 1 जुलैला आपण डॉक्टर्स डे सेलिब्रेशन करतो. पश्चिम बंगालचे दुसरे मुख्यमंत्री यांचा जन्म आणि मृत्यू 1 जुलैला होता असे सुप्रसिद्ध चिकित्सक डॉक्टर विधानचंद्र राय यांच्या स्मृतीप्रित्यर्थ आपण हा दिवस साजरा करतो. डॉक्टर हे कायमच समाजासाठी कार्यरत असतात. संपूर्ण कोरोनाच्या काळात अविरतपणे काम करून डॉक्टरकी हा नुसता व्यवसाय नसून ती एक सामाजिक बांधिलकी आहे हे नक्कीच सिद्ध झालं आहे. आणि आपण डॉक्टर आहोत याचा आपल्याला सार्थ अभिमान आहे, होता आणि राहणार. सो प्राऊड टू बी एज अ डॉक्टर. आणि याचेच कौतुक म्हणून आपण आजच्या कार्यक्रमाचे आयोजन केलेले आहे. यासाठी आपल्याला लाभलेले आजचे प्रमुख पाहुणे डॉक्टर सुधीर कुमार मुंडले सर, गेस्ट ऑफ ऑनर डॉक्टर गीता बोरा आणि माझे सर्व मित्रमैत्रिणी, मी तुमचे पुनश्च एकदा स्वागत करते. कार्यक्रमाचे प्रमुख पाहुणे डॉक्टर सुधीर कुमार मुंडले सर यांना व्यासपीठावर आणण्यासाठी GPA अध्यक्ष डॉक्टर शिवाजी कोल्हे आणि IPP डॉक्टर रूपा अग्रवाल यांना विनंती करते. सन्माननीय अतिथी डॉक्टर डॉक्टर हरिभाऊ सोनवणे आणि GPA सेक्रेटरी डॉक्टर संतोष खेडकर यांना विनंती करते. थँक्यू. वेलकम मॅम, वेलकम मुंडे सर. सर्व ऑफिस बेअरर्सना मी व्यासपीठावर येण्याची विनंती करते. व्यासपीठावरील सर्व मान्यवरांना मी दीप प्रज्वलनासाठी आमंत्रित करते. कृपया मान्यवरांनी स्थानापन्न व्हावे. डॉक्टर अरुंधती कुलकर्णी यांना मी विशेष सन्मानासाठी मंचावर आमंत्रित करते. डॉक्टर अरुंधती कुलकर्णी.
वंदे धन्वन्तरि पदयुगुलं स्वीकृत कार्ये फलसिद्ध्यर्थं वन्दे धन्वन्तरि पदयुगुलं स्वीकृत कार्ये फलसिद्ध्यर्थं बिभ्रत् कलशम् अमृतपूर्णं बिभ्रत् कलशम् अमृतपूर्णं चक्रजलौके विष्णुर्भूमि अवतीर्णौ साक्षात् विष्णुर्भूमि अवतीर्णौ देयं सौख्यप्रदानं वन्दे धन्वन्तरि पदयुगुलं स्वीकृत मयाहि सर्वे सन्तु निरामयाहि नन्दतु जगति सदा आरोग्यं नन्दतु जगति सदा आरोग्यं मा कश्चित् ननु दुःखमाप्नुयात् मा कश्चित् ननु दुःखमाप्नुयात् दातुं सौख्यप्रदानम् वन्दे धन्वन्तरि पदयुगुलम् वन्दे धन्वन्तरि पदयुगुलम् वन्दे। I request GPA President Dr. Shivaji Kolde to kindly felicitate Dr. Arundhati Kulkarni. Now proceed with our main function. I request GPA President Dr. Shivaji Kolde to kindly felicitate today's chief guest Dr. Sudhir Kumar Monde sir with shawl, pagri and memento. Thank you, Dr. Kolde. Request GPA President Dr. Shivaji Kolde to kindly felicitate our guest of honor Dr. Geeta Bora with shawl, pagri and memento. Thank you, Golden sir. I request GPA President Dr. Shivaji Kolde to say a few words about the Doctor's Day celebration. Over to you, Doctor.
गुड आफ्टरनून डॉक्टर डेजिग्नेटच्या सर्वांना शुभेच्छा देतो. आजचे प्रमुख पाहुणे डॉक्टर सुधीर कुमार मोंडले सर, सन्माननीय अतिथी डॉक्टर गीता बोरा मॅडम व इथे उपस्थित असलेले सर्व माझे डॉक्टर मित्रमैत्रिणी. आजचा हा डॉक्टर दिवस डॉक्टर बी सी रॉय द ग्रेट फिजिशियन यांच्या स्मरणार्थ साजरा केला होता. ते पश्चिम बंगालचे मुख्यमंत्री होते, दुसरे मुख्यमंत्री होते. त्यांची जयंती आणि पुण्यतिथी ही एकाच दिवशी म्हणजे 1 जुलै रोजी. डॉक्टर बी सी रॉय हे त्यांच्या निस्वार्थी वैद्यकीय सेवेसाठी ओळखले जात. आयुष्यभर त्यांनी स्वतःला लोककार्यासाठी वाहून घेतले, म्हणूनच आजचा दिवस आपण राष्ट्रीय डॉक्टर डे म्हणून साजरा करतो. कोविडच्या भयानक साथीमध्ये निस्वार्थपणे सेवा करताना ज्या डॉक्टरांना आपला जीव गमवावा लागला, अशा डॉक्टरांना श्रद्धांजली म्हणून सेव्ह द सेव्हियर्स ही या वर्षीची म्हणजे 2021 ची डॉक्टर डेची थीम आहे. खरोखरच आपण सर्व डॉक्टरांवरती या कोविडच्या काळामध्ये खूप ताण आला होता. सर्वांनी अतिशय चांगल्या प्रकारची सेवा देण्याचा प्रयत्न केला. त्यामुळेच आपण आज जीपीएचे जे सभासद डॉक्टर की ज्यांनी या कोविडच्या काळामध्ये स्वतःचे हॉस्पिटल कोविड हॉस्पिटल करून त्या सेवारूपी यज्ञामध्ये आपले योगदान दिले, अशा डॉक्टरांचा आज सन्मान करणार आहोत. आपण हे कार्य करत असताना आपले कुटुंबीय, आपली मुलं यांची आपल्याला भक्कम साथ असते. म्हणूनच ही मुली, हे मुलं तितकेच कौतुकास पात्र आहेत. आपले आई वडील सेवा देण्यात व्यस्त असताना या मुलांनी वेगवेगळ्या क्षेत्रामध्ये आपला ठसा उमटवला. त्यामुळेच जीपीए नेहमीच त्यांच्या पाठीवर कौतुकाची थाप देत असते. म्हणूनच दरवर्षीप्रमाणे यावर्षी आपण गुणवंत विद्यार्थ्यांचा सत्कार करणार आहोत. दरवर्षी आपण डॉक्टर डेच्या निमित्ताने वैद्यकीय व्यवसायात उत्तम कामगिरी करणाऱ्या जीपीए सभासद असणाऱ्या एका डॉक्टरांना जीपी ऑफ द इयर या पुरस्काराने सन्मानित करत आहोत. मित्रांनो, डॉक्टरांचे ज्ञान अद्ययावत ठेवण्यासाठी जीपीए नेहमीच कार्यशील असते. त्याचाच एक भाग म्हणून आज या चर्चासत्रामध्ये मान्यवर व्याख्यात्यांचे व्याख्यान झाले. या निमित्ताने आपण वेगवेगळ्या क्षेत्रातील तज्ञ डॉक्टरांना आपल्या व्यासपीठावर नेहमीच बोलवत असतो. वेगवेगळ्या आव्हानांना सामोरे जात असताना आपण शारीरिक व मानसिक दृष्ट्या तंदुरुस्त असले पाहिजे, सक्षम असले पाहिजे. त्यामुळेच दुसऱ्याचे आरोग्य जपताना स्वतःचे आरोग्य तितकेच महत्वाचे आणि तितकेच जपले पाहिजे असं मला वाटतं. त्यासाठी जीपीने या वर्षी डॉक्टरांच्या आरोग्यासाठी काम करायचे ठरवले आहे आणि त्यामुळेच या वर्षीची जीपीची थीम आहे सस्टेनेबल हेल्थ केअर अँड अकॅडमिक एक्सलन्स. आणि त्या दृष्टीने जीपीए कार्य करत आहे आणि सतत करत आहे. आज येथे सांगण्यास अतिशय आनंद होत आहे की जीपीने स्वतःच्या हक्काच्या घरामध्ये म्हणजे नवीन ऑफिस मध्ये 1 जुलै पासून काम करण्यास सुरू केले आहे. रोप लावले द्वारी त्याचा वेलू गेला गगनावर. खरंच गेल्या 30 वर्षापासून हे जे रोप लावलेलं आहे त्याचा सर्व माजी अध्यक्ष जीपीएचे सभासद यांच्या कष्टाने हा वेलू खरंच गगनावर पोहोचला आहे आणि हा वृक्ष सतत बहरत आहे. आजचे प्रमुख पाहुणे डॉक्टर सुधीर कुमार मुंडे सर यांनी आपल्या मी आणि हरिभाऊ सोनवणे सर यांच्या एका शब्दावर डॉक्टर डेचा प्रोग्रामला होकार दिला. कुठलंही काही विचारलं नाही, काय प्रोग्राम आहे, कसं शेड्यूल आहे. त्यांनी एका क्षणातही त्याला परवानगी देऊन टाकली. त्याबद्दल मी खरंच त्यांचे आभार व्यक्त करतो. आजच्या सन्माननीय अतिथी डॉक्टर गीता बोरा मॅडम, त्यांचा परिचय पुढे येईलच, तर थोडक्यात मी सांगतो की त्या पॅड हिरो आहे, म्हणजे सॅनिटरी पॅड्स आणि मेन्स्ट्रुअल हायजीन या क्षेत्रात त्यांचं अतिशय मोलाचं काम आहे. अशा प्रकारच्या गेस्ट आपल्याला लाभल्या त्याबद्दल मी त्यांचा आभार व्यक्त करतो. सर्वांना डॉक्टर डेच्या पुन्हा एकदा हार्दिक शुभेच्छा देतो. लॉंग लिव्ह जीपी.
Thank you, Professor. It is said that the presence of doctor is the beginning of cure, but not everyone can become a doctor because not everyone has the knowledge, skill, and patience to offer his service selflessly to the society. So yes, doctors are and will remain the backbone of the society. आपल्यातील अशाच एका डॉक्टरांचा आज आपण सन्मान करणार आहोत. या सन्मानाची नियमावली वाचण्यासाठी व सत्कार मूर्तीचे नाव घोषित करण्यासाठी IPP डॉक्टर रूपा अग्रवाल यांना विनंती करते.
नमस्कार सगळ्यांना डॉक्टर्स डेच्या खूप साऱ्या शुभेच्छा. जीपीए कडून दरवर्षी जो डॉक्टर्स डेचा प्रोग्राम साजरा केला जातो आणि त्याच्यामध्ये जीपी ऑफ द इयर ह्या अवॉर्ड डिक्लेरेशन साठी ज्या क्रायटेरियाज आपण ठरवले आहेत त्या क्रायटेरिया अशा प्रकारे आहेत की ती व्यक्ती द पर्सन शुड बी लाईफ मेंबर ऑफ जीपीए. The person should have a good medical service for the society, along with that, social service to society, as well as certain kind of commitment or dedication towards GPA related work. Next part of the criteria is the person should have no legal binding or no legal kind of allegations against the person. So with these criteria, the person has to be selected. And whoever is the best option out of the coming names is selected as the awardee or the final contestant for this GP of the Year award. So should we go for the final name? Yes. Guess करायला सांगणार नाही कारण सगळ्यांच्या इतक्या प्रामुख्याने सगळ्यांच्या चेहऱ्यावरती ते नाव मला माहिती दिसून येणारच आहे. So the GP of the year, the award is honored by GPA to Dr. Narendra Chin.
Dr. Rupa, and heartiest congratulations, Dr. Pranay sir. I request GPA Treasurer Dr. Sriram Joshi and Joint Secretary Dr. Sunil Bhujbal to please escort our awardee Dr. Narendra Kenneth sir on the dais. I request GPA Joint Secretary Dr. Appasaheb Thakre to kindly escort Dr. Sangeeta Kenneth madam on the dais. Yes, once again, heartiest congratulations, Kenneth sir. मी GPA चे पास्ट प्रेसिडेंट अँड मॅनेजिंग कमिटी मेंबर डॉक्टर महेश वाया यांना आजचे सन्मान मूर्ती डॉक्टर नरेंद्र केनेट यांचा परिचय करून देण्यास विनंती करते. डॉक्टर महेश वाया.
Thank you, Dr. Shubhda. Good afternoon, Malcolm. Good afternoon, friends. It's my great pleasure and honor to be here today to introduce my very dear and near friend of mine, Dr. Narendra Kenneth, on this auspicious occasion of Doctors' Day celebration. I am very grateful to GPA for giving me this opportunity. Every year, National Doctor Day is celebrated on 1st July for appreciating and thanking doctors for their never-ending service and contribution towards mankind. GPA every year celebrate this day and honor one such a hero for the selfless service and dedication with GPA of the Year award. I am truly overwhelmed that my dear friend Dr. Naren is receiving this award and I am here to talk about him. मनातल्या खऱ्या भावना आपण आपल्या मातृभाषेतूनच व्यक्त करू शकतो. त्यामुळे नरेंद्र विषयी बोलताना मी मराठीत बोललो तर माझ्या हृदयातून चांगले शब्द अजून व्यवस्थित येतील असं मला वाटतं. सरांचं पूर्ण नाव डॉक्टर नरेंद्र मुरलीधर केनट, जन्मगाव बारडगाव सुद्रिक, तालुका कर्जत, जिल्हा अहमदनगर, जन्मतारीख 29 जून 1966. शालेय शिक्षण म्हणजे माझ्या आजपर्यंतच्या ऐकण्यात, पाहण्यात किंवा वाचण्यात एक माणूस इतक्या वेगवेगळ्या शाळांमध्ये शिकू शकतो हे मी आतापर्यंत कधी पाहिलेलं नाही. त्यातली एक भारदस्त व्यक्तिमत्व. इयत्ता पहिली भंडारदरा डॅम, कारण वडील सिव्हिल कॉन्ट्रॅक्टर होते त्याच्यामुळे त्यांची दरवर्षी वेगवेगळ्या भागामध्ये त्यांचं काम असायचं. त्याच्यामुळे सरांचं शालेय शिक्षण जे आहे ते वाचतो मी पुढे ऐकाच. इयत्ता दुसरी जेजुरी जवळ नाझरे डॅम, इयत्ता तिसरी विहा मांडवा जालना, 5वी 6वी 7वी बारडगाव सुद्रिक जिल्हा परिषद शाळा, 8वी पुणे जिल्हा शिक्षण मंडळ शिवणे नवभारत हायस्कूल, 9वी 10वी आणि 11वी विमलाबाई गरवारे प्रशाला, 12वी SP कॉलेज. वैद्यकीय शिक्षण सुरुवातीला त्यांनी ज्ञानेश्वर विद्यापीठामध्ये ऍडमिशन घेतली होती पण काही प्रॉब्लेम्समुळे तो कोर्स बंद झाला. त्यानंतर सरांनी लोकमान्य हॉस्पिटल चिंचवड ते DHMS हा कोर्स केला कम्प्लीट. त्याच्यानंतर त्यांनी धोंडूमामा साठेतून BHMS ग्रेडेड कोर्स कम्प्लीट केला आणि आत्ताच एक 4 वर्षापूर्वी सरांनी जो आता सर्टिफिकेट कोर्स इन मॉडर्न फार्माकोलॉजी CCMP हा BJ मेडिकल कॉलेज मधून त्यांनी चांगल्या ह्यांनी उत्तीर्ण झालेले आहेत. सर सरांनी त्यांची प्रॅक्टिस जी आहे ते 29 ऑक्टोबर 1989 साली करीमनगर येथे चालू केली. एक छोटस हॉस्पिटल आणि क्लिनिक अशी ती जागा होती. 1995 साली त्यांनी करीमनगर येथेच एक नवीन सुसज्ज जागेत स्थलांतर केलं आणि टिल डेट तिथं ते वास्तव्य आहे आणि हॉस्पिटल पण तिथं त्यांचं आहे. त्यांच्या घरच्यांविषयी सांगू इच्छितो. त्यांचे आजोबा कैलासवासी पैलवान नामदेव तुकाराम केनट, त्यांना कैसर-ई-हिंद हा पुरस्कार प्राप्त झाला होता आणि त्यांचे स्वातंत्र्य चळवळीतील लोकांशी खूप घनिष्ठ संबंध आणि त्यांच्याबरोबर वास्तव्य होतं. वडील मुरलीधर नामदेव केनट शिक्षण मॅट्रिक आणि सिव्हिल कॉन्ट्रॅक्टर होते आणि त्याचाच वारसा सरांनी पुढे घेऊन पुढे मी सांगेल काय करतात सर ते. आई गृहिणी आहे. बायको डॉक्टर संगीता केनट नवले या BMS आहेत आणि सरांच्या खांद्याला खांदा लावून त्यांच्या प्रत्येक कामात आणि व्यवसायामध्ये त्या मोलाचा खारीचा नाही म्हणणार, मोलाचा महत्वाचा वाटा आहे त्यांचा. मुलगा डॉक्टर कबीर केनट, आताच त्याने MBBS चे शिक्षण पूर्ण केलेलं आहे आणि आता ही प्रिपेरिंग फॉर PG नीट. त्यांना 2 भाऊ आहेत, एक सुरेंद्र केनट त्यांचा व्यवसाय आहे आणि दुसरे डॉक्टर जितेंद्र केनट, दायरे येथे त्यांची प्रॅक्टिस आहे. वैद्यकीय व्यवसायाबरोबरच बांधकाम व्यवसायात सुद्धा सरांनी खूप प्रगती केली आहे. सरांचं 15 बेडेड सुसज्ज हॉस्पिटल आहे. सरांनी आता कोविड मध्ये सुद्धा कोविड हॉस्पिटल मधून खूप काम केलेलं आहे. गोरगरीब जनता किंवा त्यांचे कोणी पेशंट्स असतील तर म्हणजे GP प्रॅक्टिस वेगळी आणि हॉस्पिटल प्रॅक्टिस वेगळी. GP बरोबरच त्यांची हॉस्पिटल प्रॅक्टिस पण आहे की म्हणजे कुठेही करीमनगरमध्ये समजा जर प्रॉब्लेम असेल पेशंटला किंवा काही अपघात झाला असेल तर पहिल्यांदा पेशंट कुठे जातो तो नेहमी केनट हॉस्पिटलमध्ये जातो. बांधकाम व्यवसायामध्ये पण अत्यंत विचार करण्यासारखी प्रगती सरांनी केलेली आहे. करीमनगर वारजे येथे प्रथित यश बांधकाम व्यावसायिक म्हणून त्यांचा खूप मोठा नावलौकिक आहे. पुढे जाऊन शैक्षणिक क्षेत्रात काम करण्याची त्यांची आतुर इच्छा आहे. आतापर्यंत सरांच्या हॉस्पिटलमध्ये 30 वर्षामध्ये 100 पेक्षा जास्त डॉक्टर्स शिकून पुढे जाऊन त्यांच्या गावी प्रॅक्टिस केली आणि खूप चांगले नाव त्यांनी प्रसिद्ध केलेलं आहे. त्यातली आपल्या मधलं एक नाव आहे डॉक्टर सतीश जगताप, त्यांचं सहारा हॉस्पिटल आहे, ते सरांचे स्टुडंट होते. असे एक नाव आपल्याला माहिती म्हणून सांगितलं, अशी 100 नाव आहेत. सरांच्या पॉझिटिव्ह क्वालिटीज काही विचाराल तर आयुष्यात असे कधीच वाटले नाही की एखादे काम होणार नाही. म्हणजे मला जरी प्रॉब्लेम असेल आणि मी जर सरांना सांगितलं की सर असं काम करायचंय तर सरांना काय प्रॉब्लेम नाही, आपण करून टाक. म्हणजे अशी त्यांची हातोटी आणि सचोटी. आणि सरांचं समाजातील सर्व स्तरातील लोकांशी खूप सलोख्याचे संबंध आहेत आणि त्याचं नेहमी एक असतं व्हॅल्यू फॉर मनी. म्हणजे समजा आम्ही दोघं खरेदीला गेलो तर मी काढलं जर 1000चा शर्ट काढला असेल तर तो म्हणणार वेळा असते 1000 रुपये आणि तू याला करतो, तो बरोबर 200-300 मध्ये तो मला बसून देणार की तो हे करणार. म्हणजे व्हॅल्यू फॉर मनी म्हणजे ही फार महत्वाची गोष्ट आहे. आपण कुठल्याही मॉल मध्ये गेलो की आपल्याला काय आपण विचार करत नाही की हे आवडलं चला घेऊन या, त्याचं नसतं. तो म्हणणार की नाही आपण 1000 रुपयामध्ये तू एक घेतो तुम्ही 4 घेणार, असं त्याचा हे आहे. तर वेगळं मांडायचंय. आता नरेंद्र म्हणजे काय आणि कसा हे डॉक्टर संगीता वहिनींच्या शब्दात सांगतो. डॉक्टर केनट मनाने खूप प्रेमळ आहेत, सर्व कुटुंबातील सर्वांवर खूप प्रेम, घरातील सर्वांसाठी खूप खर्च करतात पण स्वतःसाठी काहीच खर्च करत नाही. व्हॅल्यू फॉर मनी. सतत कष्ट करणे. मी त्यांना कधी मी दमलो आहे, थकलो आहे, कंटाळा आला आहे असं म्हटलेलं कधी ऐकलंच नाही. सगळ्यांना मनापासून मदत करायला खूप आवडते, नवीन गोष्टी शिकायला खूप आवडते, खूप धाडसी, पॉझिटिव्ह, अनेक नातेवाईक मित्रांसाठी आधारवड. माझे सर्वस्व, माझे आवडते व्यक्तिमत्व, अतिशय हुशार पण तेवढेच भावुक, कौतुक करावे तेवढे कमीच, त्यांना आनंदी व हसताना पाहणे यातच माझा आनंद आहे. हसताना खूप छान दिसतात पण एक खंत आहे ते स्वतःसाठी कधी जगलेच नाही. अजून एक म्हणजे सर्वांना तेवढाच धाक आणि वचक आहे. आता आमच्या मैत्रीबद्दल बोलतो. काही नातं नसताना जे नातं निर्माण होतं ती मैत्री असते. कोणीही आपले नसताना अचानक आपले होते ती मैत्री असते. आई बाबांपेक्षा एखादी गोष्ट ज्याला शेअर करावीशी वाटते ती मैत्री असते. आपली छोटी छोटी गुपिते ज्यांना माहिती असतात ती मैत्री असते आणि मरेपर्यंत विसरायला लावत नाही अशी आमची मैत्री असते. नरेन म्हणजे न दिसणारा हातामधला हात. नरेन म्हणजे न दिसणारा हातामधला हात, नेहमी करता असणारी तुझी साथ. थँक्यू.
तुम्ही बोललेले अगदी प्रत्येक शब्द न शब्द आम्ही अनुभवतो. म्हणून घर ते GPA ऑफिस मध्ये जाण्यामधला मधला ब्रेक आमचा केनट सरांचं घर असतं. थँक्यू सर. मी GPA जॉईंट सेक्रेटरी डॉक्टर सुनील भुजबळ सर यांना मानपत्राचं वाचन करण्याची विनंती करते.
नमस्कार. मानपत्र माननीय श्री डॉक्टर नरेंद्र केनट. डॉक्टर डेच्या निमित्ताने जनरल प्रॅक्टिशनर असोसिएशन पुणे यांच्या वतीने देण्यात येणारा या वर्षीचा सर्वोच्च GP ऑफ द इयर
पुरस्कार आपणास प्रदान करताना आम्हाला विशेष आनंद वाटतो. आपली वैद्यकीय व सामाजिक क्षेत्रात काम करतानाची तळमळ, कामावरील अतूट निष्ठा, आपल्या कल्पनाशक्तीचे सारे बंध तोडून आपल्या परिपक्व दूरदृष्टीच्या वर दर्शन घडवते. पण तुमची स्वप्न सत्यात उतरली नाही तर नवलते काय?
आजच्या कार्यक्रमाचे प्रमुख पाहुणे डॉक्टर सुधीर कुमार मुंडे सरांना विनंती करते की त्यांनी आजचे सन्मान मूर्ती डॉक्टर नरेंद्र केनट सर यांचा पुणेरी पगडी, शॉल आणि सन्मान चिन्ह देऊन सत्कार करावा. मुंडे सर. मी GPA प्रेसिडेंट डॉक्टर शिवाजी कोल्हे अँड गेस्ट ऑफ ऑनर डॉक्टर गीता बोरा यांना विनंती करते की त्यांनी डॉक्टर संगीता केनट यांचा शॉल आणि पुष्पगुच्छ देऊन सत्कार करावा. Thank you, Geeta ma'am. Dr. Shivaji Kolle. I request today's awardee, Dr. Narendra Kenach sir, to kindly give his acceptance speech.
व्यासपीठावरील आजचे प्रमुख पाहुणे डॉक्टर सुधीर कुमार मुंडे, माननीय पाहुण्या डॉक्टर गीता बोरा, GPA अध्यक्ष डॉक्टर शिवाजी कोल्हे, सेक्रेटरी डॉक्टर सुभद्रा जोशी व सर्व GPA कार्यकर्ते तसेच उपस्थित सर्व मित्र मैत्रिणी व नातेवाईक यांना नमस्कार. डॉक्टर्स डेच्या निमित्ताने GPA ऑफ द इयर हा पुरस्कारासाठी माझी निवड केली त्याबद्दल मी GPA प्रेसिडेंट डॉक्टर शिवाजी कोल्हे व सर्व कार्यकारिणीचे आभार मानतो. सर्वप्रथम सर्वांना डॉक्टर्स डेच्या हार्दिक शुभेच्छा. माझा मित्र महेश यांनी माझा आता खूप छान सविस्तर परिचय करून दिला त्याबद्दल मी त्याच्याप्रती प्रेम व्यक्त करतो. मी त्याचे आभार मानणार नाही कारण दोघांमध्ये आभार या शब्दाला जागा नाही. प्रेम व हक्क हे दोनच शब्द आमच्या नात्यात सांगतात. चुका झाल्यास माफ करणारा, चूक केल्यास मान्य करणारा, नसली तरी मान्य करणारा. आपल्या मनाच्या भावनांपेक्षा माझ्या भावनांचा अशी ती आमची मैत्री. GPA ची स्थापना झाली त्यावेळेस पासून मी GPA चे सदस्य. GPA ने उत्तरोत्तर 30 वर्षात खूप चांगले कार्यक्रम घेतले. सर्व कार्यक्रमांचा मी साक्षी झालो. GPA ची प्रगती होत GPA आता स्वतःच्या सुसज्ज अशा ऑफिस मध्ये जाऊन स्वतःचा कारभार स्वतःच्या ऑफिस मध्ये बघतो. त्याबद्दल GPA च्या सर्व कार्यकारिणीचे आणि सभासदांचे मी हार्दिक अभिनंदन करतो. आजच्या डॉक्टर डेच्या निमित्ताने हा पुरस्कार मला माझ्या गुरुस्थानी असलेले डॉक्टर मुंडे सर यांच्या हस्ते डॉक्टर गीता बोरा यांच्या उपस्थितीत मिळाला हे मी माझे भाग्य मानतो. माझे मूळ गाव सासवडवीर रस्त्यावरती 2 किलोमीटरवर पिंपळे. माझे आजोबा त्यांची थोडीशी माहिती महेश त्यांना कैसरी हिंद हा पुरस्कार त्यांच्या सामाजिक कार्याबद्दल मिळाला. आमच्या घरी शंकरराव देव, साने गुरुजी, आचार्य अत्रे सरकार, प्रेमाताई कंटक, नरेंद्र भागवत अशा सारख्या मंडळींचा वावर असायचा. त्यांच्या विचारसरणीचा पगडा आमच्या घरावर होता. कालांतराने तो माझ्या मनावर पण आला. वडील मुरलीधर नामदेव केला, शिक्षण 10वी. व्यवसायानिमित्त कॉन्ट्रॅक्टर म्हणून ते काम करायचं. व्यवसायानिमित्त माझे वडील ते खूप काही कामं त्यावेळेला केली. त्यातले सांगण्यासारखी दिवेगार, पुरंदरचं मेंटेनन्स, भंडारदऱ्याचा मेंटेनन्स, राजस्थान मधील काही महालांचे मेंटेनन्स, या सर्व कामांच्या यासारखे व इतर अनेक प्रोजेक्ट आमचे त्यावेळेचे आमच्या नावावर आहेत. माझे शिक्षण महेशने सांगितल्याप्रमाणे खूप गावात झालं. त्यातली काही नावं तो विसरला. 7वी पर्यंत मला खऱ्या अर्थाने ऑटोमॅटिकली 12 गावचं पाणी पिणार. त्याचमुळे मी आग्रह वयाच्या 7वीत मी बारडगाव म्हणून तिथे होतो, तिथे शिक्षण पूर्ण केलं. 7वी नंतर माझा खरा प्रवास सुरू झाला. शिक्षणासाठी म्हणून पुण्याला आलो. शिवने माझ्या आत्ते सरस्वती दांगट चुलते तिथे राहत होते. म्हणजे चुलत्यांकडे पुढच्या शिक्षणासाठी येऊन शिवण्याच्या शाळेत मी शिक्षण सुरू केलं. चांगल्या शिक्षणाची ओढ असल्यामुळे सेमी इंग्लिश शिकता येईल म्हणून मी गवारेला पुढे ऍडमिशन घेतलं. दुर्दैवाने मला सेमी इंग्लिश मिळालं नाही, काही हरकत नाही. 11वी 12वी पुढे मी SP केलं. 12वीची परीक्षा ते 12वीचा निकाल या काळात, तो काळ मला रिकामा होता. त्या काळात मी कर्वेनगर येथे एक छोटी जागा शोधली, वडिलांना दाखवली, त्यांच्या मनाने मान्यतेने ती जागा विकत घेतली आणि आधार नावाचं एक छोटस घर तिथं बांधून आम्ही तिथं स्थिरावं लागलो. त्याच काळात बळवंत महादेव दातार, हे सगळे इतिहासाचं नाव आहे, तो पण तसंच येत आहे. त्यांच्या संपर्कात मी आलो. ते दातार म्हणजे दातार, देरे, कोष्टी आणि डहाणूकर त्या काळचे जे जमीनदार त्यातले दातार. आणि तिथेच आमचा खेनट हाऊसिंग डेव्हलपर्सचा जन्म पण झाला. घर पूर्ण झालं. 12वी नंतर शिक्षण, मिळालेले मार्क, असलेली परिस्थिती यानुसार ज्ञानेश्वर विद्यापीठ हा एक ऑप्शन मला होता. तिथं मी ऍडमिशन घेतलं. ज्ञानेश्वर विद्यापीठात ऍडमिशन घेतल्यानंतर कालांतराने त्या विद्यापीठाला सरकारने बंदी घातली आणि त्या विद्यापीठात जी लोक होती त्यांनी सरकारी महाविद्यालयात ट्रान्सफर केलं. तर मी पण होतो. त्याच काळात आपले GPA चे सक्रिय विवेक बेल्लमपल्ली, अश्विनी बेल्लमपल्ली म्हणजे सहकारी आणि सिनियर, त्यांची चांगली घनिष्ठ मैत्री होती. परंतु मला अंबेजोगाई किंवा मिरज इथे जायला लागला. वर्षाची फी 5,000, राहण्याचा खर्च 300 per महिना, खाण्याचा खर्च 200. शक्य नव्हतं. करायचं काय विचार केला आणि त्यावेळेला चिंचवडला लोकमान्य हॉस्पिटल येथे DHMS नावाचा एक कोर्स सुरू झाला होता. माझी पहिलीच बॅच होती. सर्व गोष्टींचा सारासार विचार करून चिंचवडला मी लोकमान्य हॉस्पिटल येथे ऍडमिशन घेतलं. ऍडमिशन घेतल्यानंतर मनात एक गोष्ट ठरलेली होती, आपल्याला काय करायचं, त्या काळात त्या करण्यासाठी काय करायचं याचा विचार करून कर्वे रस्त्यावरचं त्यावेळेचं प्रतीचं हॉस्पिटल नचिकेत रुग्णालय तिथे डे 1 पासून मी ऑब्झर्वर म्हणून जात होतो. त्या काळी एका वेळेला 10 कन्सल्टंट एका जागी सकाळी 9 ते 3 भेटणारं एकमेव ठिकाण म्हणजे नचिकेत हॉस्पिटल होतं. सर्दी खोकला तू फायरिंग एनिथिंग इज देअर ओनली. आणि सगळे सर्जन फिजिशियन त्यावेळेला स्वतः डॉक्टर विनोद केळकर हॉस्पिटलचे संचालक, त्यांचे मिसेस कल्पना केळकर ज्या ससून ऍक्च्युअली अॅनेस्थेशिया रिपेअर झाल्या, त्यांचे काका सिके केळकर जे मिलिटरीमध्ये करणार होते ते अॅनेस्थेटिस्ट, JT इलेक्ट्रोला नावाचे त्यावेळेचे खूपच चांगले आता इथे आहेतच ऑर्थोपेडिक सर्जन, मोहन जांभळे पेडियाट्रिशियन, वासुदेव पळवीकर आमचे सायकॅट्रिस्ट, प्रतिभा कुलकर्णी गायनेकोलॉजिस्ट, या सर्व लोकांबरोबर दिवस घालवायला आम्हाला. आणि दिवस घालवता घालवता आम्हाला रोज एक गोष्ट शिकत शिकत आम्ही गेलो. मी 4 वर्षात तिथे इतका ट्रेन होतो की मला लक्षात आलं की आता आपण काय करतो. इंटर्नशिप सुरू झाली. त्या काळात बाकीच्यांपेक्षा थोडं जास्त यायचं म्हणून इंटर्नशिप मध्ये पण चांगलं काम मिळालं. मी PCMCच्या हॉस्पिटल्समध्ये असायचो. तिथे थोडं येते म्हणून चांगलं काम मिळालं आणि त्याच काळात मी उरलेल्या वेळात प्रयाग हॉस्पिटल ICU डॉक्टर टेपणांची ओपीडी, हेमंत आपटेंची ओपीडी आणि विशेष करता म्हणजे डॉक्टर नरेंद्र पटवर्धनांची ओपीडी अशी जॉईन केली. इंटर्नशिप संपली दुसऱ्या दिवशी हॉस्पिटल हॉस्पिटल म्हणजे बोर्ड आणि 2 खोल्या आणि मी एवढंच. एक माणूस येऊन मला म्हणला डॉक्टर इथं काय नाही. म्हटलंय बघ इथं 2 गोष्टी मी आणि जागा आहे तुला काय झालं त्याला हॉस्पिटल म्हणतात. तो पण मान्य केलं त्यांनी आणि तिथून तो प्रवास सुरू झाला. त्या काळात आजपर्यंत आमच्या भागामध्ये कसल्याही प्रकारची इमर्जन्सी साधी ओपी पॉइझनिंग डिलिव्हरी पासून जर फायरिंग झालं तरी पण आजही नरेंद्र केंद्राचा फोन येतो. दुसरी गोष्ट जर का एअरपोर्ट टू NDA कुणी VIP जाणार असेल तर त्यांचा रूट त्या मार्गे असतो. नेहमी त्यांचा रूट A-B-C असा असतो. बी रूट आमचा आहे. कमिशनर ऑफिसवर लेटर घेऊन आज पण माणूस होतो. डॉक्टर 10 ते 12 इथून जाण्याची शक्यता तुम्ही उपस्थित राहा. त्यांच्याकडे रेकॉर्ड असतो. त्या काळातलं यश होतं. हॉस्पिटल सुरू केलं त्यावेळेला मनात द्विधा होती आपण कुठे करायचं. केलं तर हॉस्पिटल चालू केल्यानंतर मला दामले नावाचे भेटायला आले. काही केस असेल तर बोलू. तर मनातली द्विधा बोलून दाखवली सर कदाचित मी कुठेतरी सासवडला प्रॅक्टिस करेल. एक सल्ला दिला मी वयाच्या 60व्या वर्षी तुला भेटतो कारण हेच मी शिफ्टिंग करतो. एका जागी बसलाय मी तुला भेटायला आलोय तुझं नाव बरं आहे असं मला वाटतं शिफ्टिंग करू. त्यांनी अनाऊन्सपणे दिलेला सल्ला मी ऐकला. त्याच जागी बसून पुढे आपलं काम करायचं ठरवलं. पुढे त्याचे सर्व फळं मी आजही भोगतोय. त्यांच्या सल्ल्याबद्दल मी आजही त्यांचे आभार मानतो. जेव्हा मी हॉस्पिटल चालू केलं तेव्हा डेक्कन टू उत्तम नगर प्रत्येक एरियाला एक ठराविक टप्प्यात हॉस्पिटल होतं. केनेट हॉस्पिटल एक होतं. त्यावेळच्या हॉस्पिटलमध्ये एक्सरे, सोनोग्राफी, थिएटर, ICU, व्हेंटिलेटर सर्वात महत्वाची गोष्ट अख्ख्या भारतामध्ये केनेट हॉस्पिटल हे एकमेव होतं ज्याच्याकडे स्वतःच टॉप एंड लिथोट्रिप्सी होतं. याच्यावर चर्चा झाली त्यावेळेला ती मोडॅलिटी फार स्पेशल मानली जायची. आता ते सोपं झालंय पण त्यावेळेला लिथोट्रिप्सी सकट हॉस्पिटल असणारं हे केनेट हॉस्पिटल हे एकमेव होतं. आणि ज्या वेळेला आम्ही तिथं काम चालू केलं तेव्हा प्रत्येक वेळेला माझ्या खांद्याला खांदा म्हणजे बघण्यासाठी थोडा 2-3 गोष्टी होतो. एक हॉस्पिटल, बांधकाम व्यवसाय, तिसरा थोडस राजकारण. राजकारणात ऍक्टिव्ह कधी नव्हतो पण एक अँगल होता आणि त्यावेळेला मी विचार केला की आपल्याला यातलं काय निवडायचं आहे. तर मी हॉस्पिटल प्रॅक्टिस निवडलं. कारण असं होतं म्हणजे घरची परिस्थिती बेताची होती. हॉस्पिटल प्रॅक्टिस ही शाश्वत होती जे काय असेल तीच शाश्वत गोष्ट म्हणून मी हॉस्पिटल प्रॅक्टिस निवडलं. म्हणजे आठवतंय मी बघायला गेलो आमचं लग्न कांदेपोळे करून झालंय. तर तिला एकच प्रश्न विचारला मी म्हणजे प्रॅक्टिस बरी आहे पण मी कदाचित प्रॅक्टिस सोडून राजकारणात गेलो तुला हॉस्पिटल सांभाळायला. तेव्हा ती हो म्हणली आता झालंय उलट. गेल्या 5 वर्षात मी जिथे हॉस्पिटल सुरू केलं होतं जागा मला कमी पडायला लागली. व्यावहारिक चातुर्य खूप होतं. त्या चातुर्याच्या जोरावर माझ्या शेजारचीच एक जागा मिळवली. जागा मिळवल्यानंतर तिथं बांधकाम पण कुठलंही काम होताना अडचणी ह्या येणारच आहे. त्यावेळेला नाही पाहिजे, पण ओघाने आलं म्हणून सांगतो. मला एक लोकल नगरसेवक त्यांनी त्रास दिला. सुरुवातीचा काळ मी थोडा सहन केला, नंतर त्याला नरेट किरणचं खरं रूप दाखवलं. 5 मिनिट त्याच्यानंतर काही पुढे झालं नाही आणि ते हॉस्पिटल आता तिथे जिथे माझं किरण हॉस्पिटल आहे त्या ठिकाणी दिमागात उभा आहे. म्हणजे सर्व प्रवासात माझ्या कुटुंबाची प्रेरणा या ग्रस्तानी आहेच, पण आपण काम करत असताना काही ना काही आपल्या मनात एक असतोच, कुठून काय होतं. लहानपणी मी ऐकायचो, मी कधी ते बघितलेलं नाही, पण पाचशेला एक जगदाळे मामा रुग्णालय आहे आणि ते जगदाळे मामा नावाचे गृहस्थ चालवतात जे डॉक्टर नाही आहेत. असं वाटायचं की जो माणूस डॉक्टर नाही तो बार्शी सारख्या ठिकाणी एवढं मोठं हॉस्पिटल चालवतो तिथं डॉक्टर आहे, मी काय नाही होत. म्हणून मला हॉस्पिटल चालवताना कधी असं मागे बघायची वेळ आली नाही, कधी भीती नाही वाटली. आणि त्याचबरोबर किल्लारीचा जेव्हा भूकंप झाला तेव्हा मी किल्लारीला गेलो होतो आणि तिथं विवेकानंद हॉस्पिटलला भेट दिली. ते एक माझा प्रयत्न असतो. बार्शीतच दुसरं जे हॉस्पिटल आहे नरगिस मेमोरियल हॉस्पिटल आहे, तिथं कॅन्सर हॉस्पिटलमध्ये जास्त काम केलं जातं. आजही CS सर्व्हिस वरती जगात पहिल्या नंबरचं ते रुग्णालय आहे. म्हणजे बार्शी असं ठिकाण आहे जर तुम्ही आजही गेलं तिथं ओपन करणार तिथे हे हॉस्पिटल इतक्याने चालतं. तर जागा प्लेस याला काही महत्व नाही, काम केलं पाहिजे आणि तेवढे डेव्हलपमेंट केलं पाहिजे. या सगळ्याच याच्या बरोबर सगळ्यात महत्वाचं दुसरं आवडतं क्षेत्र हे बांधकाम व्यवसाय. मला बांधकाम व्यवसाय करताना कधी पैसे ह्या गोष्टीसाठी मी तो व्यवसाय बघितला नाही किंवा मी ठरवून ते वेंचर करायचं म्हणून गेलो नाही. त्याची एक मोठी स्टोरी आहे, ते ऐकायला लागलं तर एक तास जाईल. माझा बांधकाम व्यवसाय जेव्हा सुरू झाला ते दातार नावाचे गृहस्थ माझ्यावर पाठवू शकतात. आजही ते 90 वर्षाचे काम करतात. आज पण मी त्यांच्याकडे जाऊन एक कोरा पेपर ठेवतो, सही करतात. कित्येक अडचणींच्या कामात लोक मला घेऊन जातात, त्यांची सही लागणार आहे, मी गेलो की सही घेऊन द्या. तर या कामाचं त्या काळापासून काम बहरत गेलं. सुरुवातीला जेव्हा आम्ही कर्वेनगर मध्ये रिअल इस्टेट मध्ये कामं केली, 17,500 रुपये वरून किचन असे आमचे प्रोजेक्ट होते. आमचे प्रोजेक्ट 2.5 कोटी आणि अबव असं सिंगल युनिट असे आम्ही लिहितो. 17,500 ते 2.5 कोटी हा प्रवास खूप मोठा आहे. 2.5 कोटी रुपये आणि हे सगळं करत असताना आम्ही एक ठरवून घेतलं की आपलं कार्यक्षेत्र काय. तर आम्ही आमचं कार्यक्षेत्र फिक्स केल्यामुळे डायरेक्ट कंट्रोल आहे. तुम्ही बाकीच्या मंडळींची आम्हाला फारसं हे होत नाही. या सर्व धकाधकीच्या जीवनामध्ये माझा मुलगा कबीर मोठा होत होता. 12वी नंतर त्याने भारतीय विद्यापीठामध्ये ऍडमिशन घेऊन MBBS शिक्षण पूर्ण केलं आणि शिक्षण पूर्ण केल्यानंतर इंटर्नशिप संपल्यावर कोविडची लाट आली. स्वतःहून ससून मध्ये कोविडच्या फर्स्ट लाट, जेव्हा कोविड म्हणलं तरी लोक पळून जायचे, तर अशा वेळेला त्यांनी ससून आणि केनेट हॉस्पिटलमध्ये पूर्ण वेळ काम केलं. मुलगा फार लोभस आहे. लव यू कबीर. त्याचबरोबर माझा पुतण्या पुन्हा त्यांनी माझ्या बरोबर आता तोही मेडिकल एज्युकेशन घेतोय. पण मेडिकल एज्युकेशन घेत असेल तरी माझ्या खांद्याला कोविडच्या काळात काम केलं. माझी दुसरी पुतणी आहे, नागरी मुलगी आहे आमच्यासोबत. काम नाही केलं, ती मेडिकल क्षेत्रात काम करते. भविष्यात त्या कामात आपलं नाव. आजपर्यंतच्या प्रवासात अनेक चांगले मित्र मला मिळाले. प्रत्येक नशिबाने दुसरे मित्र नाही, मित्र खूप आहे. त्यापैकी लगेच सांगतो म्हणजे शंका नाही राहणार. त्यापैकी म्हणजे इथं ओळख करून दिली तो तर सगळ्यांना माहिती आहे. माहिती नसलेल्या मित्रांपैकी दिनेश, प्रेमा, सूर्यकांत माने, 2 संतोष. संतोष इथं दिसतोय, संतोष गोसावी आणि संतोष कवित, हरिभाऊ, विवेक, शिवा, अनिल, संजय बाब, RD, अप्पा, PH, श्रीराम जोशी, डबल पार्ट असं कारण शोधतात. जगताप सुनील ही व याच्या खूप नाव आहेत, दिवसभर लागेल. त्याचप्रमाणे अनेक मैत्रिणी पण आहेत, त्यातली धनु, अश्विनी, नैना. नैना म्हणजे मुंबईसाठी तुम्हाला माहिती असेल ती वेगळ्या ठिकाणी सरांना माहिती असेल. शुभदा, वसुधा, दीपा, राजेश्वरी मैत्रिणी सुद्धा मला लागल्या. या सर्व प्रवासात अनेक व्यक्तींशी घनिष्ठ संबंध घेत गेले. प्रत्येक क्षेत्रातल्या लोकांची एक लिस्ट आहे. काही वैद्यकीय क्षेत्रातली लिस्ट आहे, त्याच्यातली नाव घेण्यासारखे डॉक्टर सुधीर कुमार मुंडे, डॉक्टर पी एस करमरकर आहेत, डॉक्टर के एच संचेती आहे. हे माझ्या ओळखीने वैद्यकीय व्यवसायातले माझ्या गुरुस्थानी असलेले कालांतराने माझे मित्र झाले. तर असे खूप लोक आहेत. वैद्यकीय क्षेत्रात असलेले, राजकीय क्षेत्राशी निगडीत असलेले आमचे आप्पा दगडे असतील, आमचे बाळासाहेब मोकाटे असतील, ते आमचे आज घनिष्ठ मित्र तुमचे फॅमिली मेंबर आहेत. मला संगीता, कबीर, कुणाल म्हणजे भाऊ, सासरची मंडळी, विशेष करून माझी सासूबाई यांचे खूप प्रेम लागते. आज मी व माझे दोन्ही भाऊ स्थिर स्थावर असल्यामुळे आई वडील ही आनंदी आहे. आई वडिलांच्या सर्व इच्छा पूर्ण करत आल्या. समाजासाठी समाजसेवा करून काही प्रमाणात रुग्ण भेटत आहे, त्यामुळे मी खुश आहे. एक भाग सांगतो. आम्ही जेव्हा आता कोविड हॉस्पिटल चालवलं, आज खूप लोकांना कोविड हॉस्पिटल नंतर सरकारची भीती वाटते. मला भीतीच नाही. तरी आलं मला तर वाटतं यावंच, म्हणजे त्यांना कळेल की लोक चांगलं म्हणजे खूप काम करतात. माझ्याकडे पेशंट ऍडमिट झाले, मला एकही पेशंटनी एक शब्द काही विचारला नाही. या कोविड मध्ये 70 पेशंट ऍडमिट झाले. 70 काही तक्रार नाही केली, सर्व बरे झाले. एक दुर्दैवी मृत्यू झाला. गुरुविना व्यर्थ जीवन, गुरुविना ज्ञान नाही आणि ज्ञानाविना आत्मा नाही. असे लाभलेले गुरु डॉक्टर विनोद केळकर सर, डॉक्टर करमरकर सर, डॉक्टर मुंडे सर, तसेच या संपूर्ण प्रवेशात प्रत्येकाकडून मला काही ना काही शिकायला मिळाले. असे सर्व गुरु आपल्या सर्वांना आदर व्यक्त करून मी आभार मानतो सर्वांचे. इथे जमलेल्यापैकी बरेचसे लोक MBBS, BMS, BHMS, BHMS या शैक्षणिक पात्रतेचे. आपली शैक्षणिक पात्रता ही आपल्या मनात आपल्याला आपल्या प्रगतीमध्ये अडसर वाटत असतो. पण मला कधी वाटलं नाही, तुम्हालाही कधी वाटलं नाही, आपण आपल्या क्षेत्रात अनबिटेबल असतो. त्यासाठी अपग्रेडेशन ऑफ नॉलेज हे डे टू डे पाहिजे, जे GPA करतो. त्यामुळे GPAचा पण कोरोनाच्या साथीत जनरल प्रॅक्टिशनरचा रोल किती महत्वाचा आहे हे आता अधोरेखित आहे. कोरोना नसतानाही जनरल प्रॅक्टिशनर ही संकल्पना ही अत्यंत महत्वाची आहे. फक्त ती आपल्याला वाटली पाहिजे की याला खूप महत्व आहे. शालेय जीवनात तिकडे बारडेगावला करत असेल, कुमार सप्तर्षींचं आणि कुमार सप्तर्षींच्या संपर्कात त्या शाळेच्या स्वतः डॉक्टर होते, पण प्रॅक्टिस करत नसल्याने हल्ला बोल, आणि त्या हल्ला बोलचा स्वभाव आमच्या मानावर फार पण हे सगळे हिरो वाटायला लागले. पण जेव्हा प्रॅक्टिस सुरू केली तेव्हा लक्षात आलं की हल्ला बोल इथे चालत नाही, हो म्हणलं पाहिजे. काळानुसार आम्ही हल्ला बोल विसरलो, हो म्हणायला शिकलो की आम्ही केलेली ऍडजस्टमेंट. त्या ऍडजस्टमेंटचे पुढे आम्हाला खूप फायदे झाले. त्याच काळात माजी पंतप्रधान चंद्रशेखर ते तेव्हा पंतप्रधान नव्हते, पण त्यांनी भारत पदयात्रा चालू केली होती. राशीन श्रीगोंदा आम्ही त्यांच्या पदयात्रेत सामील झालो होतो. मी स्वतः खूप लहान होतो, पण त्यावेळेला त्या पदयात्रेचा फायदा एवढा झाला की खरं समाजातलं रूप काय हे आमच्या लक्षात आलं. प्रत्येक माणसाला आयुष्यात संधी चालून येते. आलेली संधी आपल्याला ओळखता आली पाहिजे आणि त्या संधीचं योग्य आपल्यासाठी फायदा करून घेता आला पाहिजे. हे जर तुमच्या लक्षात आलं तर तुमची उत्तरोत्तर प्रगती ही नक्की होणार आहे. वित्त आणि विद्या हे एकत्र मिळत नाही, पण विद्येमुळे मिळालेलं वित्त तुम्ही मिळवून घेऊ शकत नाही. वित्त आणि विद्या ह्या एकाच नाण्याच्या दोन बाजू जशा लक्ष्मी आणि सरस्वती. त्यामुळे खूप विद्या कमवा, मला वित्त मिळणार. आपण सगळे जनरल प्रॅक्टिशनर वयाने लहान अनुभवानुसार एवढं सांगतो, माणूस प्रगती करताना पैशाची गरज असते. मी जेव्हा मला पैशाची गरज होती तेव्हा बँका लोन देत नव्हत्या. माझ्या आयुष्यात मी जेव्हा जागा घेतली तेव्हा पैसे नव्हते. किर्लोस्कर कमिन्स मध्ये बेसिक चालू ते आज पण आहे. आणि ते पैसे ते व्याजाने देतात, त्याला व्याज 3% महिना आहे. मी माझ्या आयुष्यात पहिल्यांदा घेतलं आणि त्या घेतलेल्या पैशाचा मी पुरेपूर फायदा करून ती जागा हॉस्पिटल. आज आपण व्याज म्हणले की लोक घरी येतात, ते घ्या. त्यावेळेची परिस्थिती कशी नव्हती. तुम्ही पण जेव्हा लोन घेता 100 वेळेला विचार करा. असं का सांगतोय तर लोन कसलं लोन मिळतं, पर्सनल लोन. त्यावेळेला मात्र विचार करा. पण एखाद्या फिक्स असेट साठी तुम्ही काही लोन घेणार असाल तर एकदाही विचार करू नका, लोन घ्या. आणि जेही लोन घ्या त्यावेळेला तुमच्या कॅश फ्लोचा विचार करा. तुम्ही जे काय बॅलन्स शीट लिहिता ते बॅलन्स शीट वेगळं असतं, कॅश फ्लोचा विचार केला पाहिजे आणि हे घेऊन आपण लोन घेतलं पाहिजे. घेतलंच पाहिजे असं नाही फिक्स असेट साठी काय केलं असेल, पण विचार करून घ्या. हे सांगण्याचं कारण एवढंच आहे, हे सगळं आता माझ्या वयाच्या 17व्या वर्षी पहिल्यांदा व्यवहार सुरू केला. आज माझं वय 55 वर्ष संपलंय. थोडंफार मला आता अनुभव आलाय तुम्हाला सांगितलं. तर ते शेवटी एक गोष्ट नक्की सांगेल, जे 2 व्यवसाय मी सुरू केले त्या दोन्ही व्यवसाय गती चांगली आहे, चांगलं काम करत आहे. आजही आमच्या भागात काही प्रोजेक्ट असले लोक आवर्जून माझ्याकडे त्या प्रोजेक्ट बद्दल माझं मत घेतलं जातं, तुला काय वाटतं विचारलं जातं आणि दिलेल्या मताचं ते पण विचार करतात. ह्या मंडळामध्ये काहीतरी आहे. हे सगळं झालं. तसंच हॉस्पिटल मध्ये मला एकदा लोकांनी विचारलं, अरे तू काय करतो असं. हॉस्पिटल प्रॅक्टिस एवढ्यासाठी करतो मी, जसं सांगितलं हॉस्पिटलमध्ये जे काय मला मिळतं हे माझं चरितार्थाचं साधन आहे. आणि चरितार्थाचं साधन नुसतं नसून ते मला विद्येमुळे मिळणारा विद्या आहे, तर कुठे हिरवणार नाही. आज रात्री 12 वाजता कुठला तरी सरकारचा एक अध्यादेश आला ना, तर तुमच्या नावावर फक्त 2 खोल्या बाकी भारत सरकारच्या नावावर असं होतं. असं होण्याची शक्यता दाट आहे. म्हणजे डिग्री काय भारत सरकार करणार नाही. मग ते शाश्वत गोष्ट आहे, नुसती शाश्वत आहे असं नाहीये. तर त्या शाश्वती बरोबर त्या शाश्वती बरोबर समाजाची सेवा करण्याचा तुम्हाला योग मिळतो, समाजामध्ये तुम्हाला आदर मिळतो आणि एक प्रकारचं तुम्हाला आत्मिक समाधानही असतं. तर हे सर्व विचार करून जरी मी व्यवसायात प्रतियश असले तरीही पूर्ण वेळ प्रॅक्टिस करतो मी. आजही तुम्ही सकाळी 9 ते 1 संध्याकाळी 6 ते 10 जर असं तर मी हॉस्पिटलमध्येच भेटतो. सत्य शेवटी मला एक सांगायचं की सर्व आपण वैद्यकीय व्यावसायिक आहोत. आयुष्य आपल्या गोष्टी सगळ्या अशाश्वत असतात. हे सगळं असताना आपण सेकंड सोर्स ऑफ इन्कम याचा विचार करून त्याच्यासाठी पण काहीतरी प्रयत्न केले पाहिजे. याचबरोबर माझे आई वडील इथे आहेत. त्यांना नमस्कार करून आजचं भाषण संपवतो. धन्यवाद.
थँक्यू व्हेरी मच सर. सरांचा प्रवास ऐकला. 2 खोलीमधून आज दिमाखात कडवेनगरच्या चौकात खेण्यात हॉस्पिटल चालू आहे आणि ते त्याच दिमाखात आहे कारण मला आठवतं परवा दिवशी मी कोल्हे सर आणि हरिभाऊ सोनवणे सर इन्व्हिटेशन द्यायला गेलो होतो आणि इन्व्हिटेशन आम्ही कुठे दिलं तर ऑपरेशन थिएटरमध्ये. सो खरंच त्याच दिमाखात सर आहेत आणि सरांचं हॉस्पिटल असंच राहणार याची आम्हाला खात्री आहे. वन्स अगेन हार्टिएस्ट कॉंग्रॅच्युलेशन सर अँड वी GPA रिअली प्राऊड ऑफ यू. कोविडच्या काळात ज्यांनी आपले कोविड रुग्णालय आता जसं केनेट सरांनी सांगितलं नुसतं दवाखाने आणि हॉस्पिटल तर आपल्या बऱ्याच जणांचं आहे, पण कोविड रुग्णालय चालवणं ही ज्या सगळ्यांनी जी अविरतपणे सेवा दिलेली आहे त्यांचा आज आपण इथे सन्मान करणार आहोत. मी प्रमुख पाहुणे डॉक्टर सुधीर कुमार मुंडे सरांना खऱ्या अर्थाने कोविड योद्ध्यांचा सत्कार करण्याची विनंती करते. डॉक्टर मंगेश वाघ will collect the award on behalf of Hadapsar Medical Association. केनाट हॉस्पिटल देखील कोविड हॉस्पिटल होतं, पण विशेष म्हणजे कबीर केनाट यांनी ससून बरोबरच केनाट हॉस्पिटलची पण धुरा सांभाळली. सो डॉक्टर कबीर केनाट. मी डॉक्टर कबीरला ससूनची ड्युटी करून केनाट हॉस्पिटलमध्ये काम करताना पाहिजे. सो हार्टिएस्ट कॉंग्रॅच्युलेशन डॉक्टर कबीर. Yes, sir. डॉक्टर अप्पासाहेब काकडे, डॉक्टर राजेश्री काकडे दावेली येथे अविरतपणे कष्ट करत आहेत कोविड रुग्णांसाठी. डॉक्टर मंगेश खटावकर, डॉक्टर मंगेश खटावकर. राष्ट्रवादी डॉक्टर सेलच्या तर्फे आणि स्वतः साई हॉस्पिटलच्या तर्फे अविरतपणे कोविडच्या काळात काम करणारे आपले डॉक्टर सुनील जगताप सर. डॉक्टर संभाजी मांडे, डॉक्टर प्रवीण दरक, डॉक्टर सुनील आंबोरे. येस, डॉक्टर प्रवीण दरक. नंतवडी येथे त्यांचं हॉस्पिटल आहे. कॉंग्रॅच्युलेशन डॉक्टर दरक सर. डॉक्टर सुनील आंबोरे, डॉक्टर प्रशांत दौंडकर, डॉक्टर रवींद्र जोशी, डॉक्टर मोनाली अजित सिंग पाटिल, डॉक्टर मोनाली अजित सिंग पाटिल, and I request Dr. Ajit Singh Patil. Moria Hospital. डॉक्टर सागर लोढ़ा, डॉक्टर वैशाली लोढ़ा, once again heartiest congratulations for all of you to run the COVID hospital and to serving the society. दरवर्षीप्रमाणे आपण याही वर्षी ज्या मुलांनी आपापल्या आवडत्या क्षेत्रात उत्कृष्ट कामगिरी केली आहे त्यांचा सत्कार करणार आहोत. पण कोविडच्या सिच्युएशनमुळे आपण मुलांना न बोलवता त्यांचा सत्कार त्यांचे पालक स्वीकारतील. आम्ही आजचे प्रमुख पाहुणे डॉक्टर सुदीप सर आणि डॉक्टर गीता बोरा मॅडमला विनंती करते त्यांचं फेलिसिटेशन करण्यासाठी. साहिल मेनन, winner of many fashion shows and modeling and also TV serials and many ads, the son of Dr. Shabana. Ojis Guzar and Aradhya Guzar, both are black belt in karate. I request Dr. Guzar, Kavita Guzar and Dr. Pawan Guzar. Asmi Mahamuni, I request Dr. Saili Mahamuni to come on dais. Asmi Mahamuni won the Indian Fashion Glory Award. Heartiest congratulations to Asmi. Mihir Shinde, I request Dr. Mohini Shinde. Mihir Shinde received green belt in karate. Mohit Wag. I request Dr. Sanjay Wag and Dr. Deepa Wag. Mohit Wag completed MBBS with 63% mark. So heartiest congratulations, Dr. Mohit. Chaitanya Kashit for best performance in 10th. I request Dr. Asha Kashit. Master Sharvil Sinkar. I request Dr. Chetna to come forward. Sharvil won the gold medal in Conquest Olympiad. Please congratulations, Master Sharvil. He is just 4 years old. Dr. Nisha Shah. Jinal Shah cleared MBBS with 67% mark and Pooja Shah MA Psychiatric B.Ed first class first. So heartiest congratulations, Jinal and Pooja. Sampada Joshi. I request Dr. Sampada to come forward for Soham Joshi. Soham Joshi got admission in Cincinnati University for medical engineering. Dr. Vidyut Patel. Dr. Mamta Arora. Kashish Arora got gold medal in state level in boxing championship. Leena Bonde. Anushka Bonde, second prize in allocation. Dr. Garudkar. I request Dr. Kakade to come on dais to collect the award for Aradhya Garudkar for excellence in science and English Olympiad. Dr. Nilin Patil and Dr. Seema Patil to come forward. Srushti Patil got admission in MBBS. Dr. Vidyulata Doshi. Her daughter Maitri Doshi got admission in BJ Medical College. Dr. Vidyulata Doshi, heartiest congratulations to Maitri. Dr. Smita Dongre. Heartiest congratulations to Aryan Dongre for cleared Homi Baba. Dr. Birde for Ranjan Birde. And I request Dr. Rachana also. Yes, congratulations to Ranjan. Received national gold medal. Dr. Deepali Moe. Dr. Rajdeep Moe cleared JEE. So heartiest congratulations for excellent performance in JEE. Dr. Sheetal Kolle. The awardee is again Master Sarvesh Kolle. Cleared Mastermind Maths and Science rank 1. Sarvesh Kolle. Dr. Deepali wants to share a few things about Rashti.
Thank you, dignitaries and dais and guests for giving me chance to talk. I just wanted to talk about Rajdeep. पास तर सगळेच जण होतात, चांगले मार्क सगळेच जण मिळवतात. पण राजदीपनी यावर्षी एक खूप मोठं काम केलं रेड लाईट एरियामध्ये. When he asked me की आई मला सोशल वर्क करायचं कोविड रिलेटेड मी काय करू, then I advise him की जी प्रिव्हिलेज अंडर प्रिव्हिलेज आहेत त्यांच्यासाठी काम कर, काहीतरी कर. But then he said की मी ट्रान्सजेंडर साठी काय करू, मी करणार त्यांच्यासाठी. अशी अंगात एक शिरशिरी गेली की बापरे, हा रेड लाईट मध्ये जाऊन काम करणार, ही जस्ट 19 कम्प्लीट. पण जेव्हा मी त्याशी बोलले, मग त्याला मी काही गोष्टी सांगितल्या, देन ही म्हणजे मला त्याला लक्षात आलं की मला फार विशेष आवडलेलं नाहीये हे. अँड देन ही स्टॉप टेलिंग मी द थिंग्स. मग नंतर लक्षात आलं की हा सांगत नाहीये तर आपणच बोललं पाहिजे. मग मी बोलायला लागले, देन ही स्टार्टेड शेअरिंग हिज एक्सपिरियन्सेस. देन आय रिअलाइज ही इज व्हेरी मॅच्युअर्ड. आधी असं वाटलं होतं की जस्ट 19, कदाचित बिहेवियरल मॅच्युरिटी नसेल, थिंकिंग मॅच्युरिटी तेवढी नसेल, तर आपण खरोखर त्याला अलाव करायचं का. देन ही मेट IPS डॉक्टर रुपल अग्रवाल मॅडम, कॉर्पोरेशनचे डॉक्टर्स. ही पर्सनली वेंट देअर अपॉइंटमेंट घेऊन मे महिन्यामध्ये, एप्रिल एंड आणि मे जेव्हा खूप पीक होता कोविडचा, अँड तिथे जाऊन भेटून त्यांच्या परमिशन काढून बोलून ही लर्न अ लॉट ऑफ थिंग्स. ही लर्न हाऊ टू निगोशिएट, हाऊ टू टॉक. अँड देन ही स्टार्टेड वर्किंग इन दॅट एरिया. ऍक्च्युली बुधवार पेठेमध्ये सगळ्या गल्ल्यांमध्ये काउन्सिलिंग करत मुलं म्हणजे होती. आणि तेव्हा मला खूप टेन्शन यायचं आणि भीती वाटायची. त्यांनी मला सांगितलं की आई, त्या एरियामध्ये खरोखर कामाची खूप गरज आहे. तर काय टोल्ड हिम की तू करायची ते कदाचित गरज नसावी, कारण तिथे NGO काम करतात, तिथे मुलांसाठी त्यांच्या शिक्षणासाठी खूप काम करतात, त्यांच्या एज्युकेशनसाठी, कम्युनिकेबल डिसीजेस साठी तिथं NGO काम करतात. पण देन ही सेड की आई, हे सगळं पेपरमध्ये, हे सगळं तुम्हाला माहितीये, पण ऍक्च्युली परिस्थिती अशी आहे की त्या वर्कर्सना काहीच माहिती नाहीये. they really don't know about the communicable diseases. त्याची severity माहिती नाही. They are very reluctant to take the vaccine. Then they started doing counseling there की vaccine का घेतलं पाहिजे, but still they are reluctant to come forward for the vaccine. मग नंतर यांनी फूड डोनेशन सुरू केलं, क्लॉथ डोनेशन सुरू केलं त्या एरियामध्ये, की त्यांना थोडंसं आमिष दाखवायला की तुम्ही वॅक्सिन घेतलं तर साडी मिळेल, फूड पॅकेट मिळेल. मग अशाने ह्या गोष्टी केल्यानंतर तिथली ट्रान्सजेंडर लोक वर्कर्स वॅक्सिन घ्यायला पुढे आली. अँड दिस जर्नी वॉज व्हेरी लाईक, काय म्हणूया आपण, खूप महत्वाचा, खूप मोठा. आणि ही सगळी मुलं साधारण 19 ते 20-22 वर्षातल्या 4-5 मुलांनी मिळून हे काम केलं. आज सुद्धा राईट नाव ही इज डोनेटिंग फूड देअर इन द रेड लाईट एरिया. 500 लोकांना 500 फूड बॅग्स आज ते डोनेट करतात. सो आय एम रिअली प्राऊड ऑफ यू. थँक्यू.
हार्टिएस्ट कॉंग्रॅच्युलेशन्स टू राजदीप. आणि खरंच GPA फॅमिली अशी मल्टी टॅलेंटेड पर्सनॅलिटीजने भरलेली आहे. सो लॉंग लाईफ GPA. नेक्स्ट इज पंकज बलदवा फॉर यश बलदवा. ही गॉट ऍडमिशन फॉर MBBS at मिरज गव्हर्नमेंट कॉलेज. नेक्स्ट इज सुमेध खरे. I request Dr. Yogesh Khare. Sumit Khare is a winner of official Pune Beatbox Championship 2020. Then another awardee is Dr. Charuta Khare, gold medal in javelin throw. So heartiest congratulations to Sumit and Charuta. Priyanka Kakade. Srushti Kakade cleared JEE with 90% marks. Heartiest congratulations, dear Srushti. Sakshi Bhavane got admission for MBBS in Krishna Medical Institute, Karad. Sakshi Bhavane. Next is Dr. Dandraj Helambe for Kunal Helambe. Completed MS in quantum physics. I request Helambe madam also to come forward. And heartiest congratulations to Kunal. Completed MS in quantum science. Dr. Sunil Ambore. For excellent performance of Anuj Ambore. Yes, Dr. Sunil Ambore. Dr. Rajendra Jagtap. Yuvraj Jagtap got MBBS admission at Navle and CET score is 99%. Dr. Rajendra Jagtap. Dr. Rajendra Khedkar. For son Shrish Khedkar, actor, selected as Chhatrapati Sambhaji Maharaj in Star Pravah serial. And Darsh Khedkar got Best Child Actor Award for Bangladesh International Short Film Festival at Dhaka. So once again, heartiest congratulations to all.
Shrish donated all his earnings to CM Fund.
Thank you very much and heartiest congratulations to all achievers. Now I request our guests to felicitate our GPA life members and annual members. I will just mention the names. Those who are present, please come forward. Dr. Alka Shelekari. One thing I want to mention about Alka, she is very much interested in academics. She stays in USA, but for academic session, she took the life membership. So heartiest congratulations to Dr. Alka. Dr. Pragnya Sapkar, Dr. Prashant Sapkar, Dr. Prahlad Shinde, Dr. Shantanu Jagdale, Dr. Renuka Gomkar, Dr. Sharad Shingade, Dr. Smita Darshankar, Dr. Chetna Singhar. Even Chetna also took life membership for the academic session. So hats off to our scientific committee for guiding us to conduct such live sessions. Dr. Mehboob Patel. Dr. Mamta Arora. Dr. Monali Ajit Singh Patil. Dr. Monali Patil. Dr. Sagar Lodha. Annual members Dr. Kamini Hinge, Dr. Trupti Joshi, Dr. Mohini Shinde. Yes, Trupti Joshi. Mohini Shinde, Saili Mahamuni, and Neha Naiknavi. I request all annual members to continue as a life member. Thank you, all of you. I know you all must be eagerly waiting to hear our today's chief guest, Dr. Sudhir Kumar Mundle sir. Sudhir Kumar Mundle sir, he is a MD General. I request all of you to please be seated. So today we have chief guest Dr. Sudhir Kumar Mundle sir and our guest of honor Dr. Geeta Bora. मासिक पाळी ही एक समस्या होती आणि आहे. मासिक पाळी हा जरी नैसर्गिक बदल असला तरी फार म्हणजे वाईट परिस्थिती काही स्लम एरियामध्ये आहे की जिथे मासिक पाळीला एक समस्या समजतात. मासिक पाळी आली की सामाजिक वागणूक, घरात मिळालेली वागणूक, काही अनेक अडचणींना सामना करावा लागतो. अशा या मासिक पाळीमध्ये मेन्स्ट्रुअल हायजीन कसे राखावे, सॅनिटरी पॅडचा वापर कसा करावा हे आपण तर सांगत आलेलोच आहोत. पण ते ब्लिडिंग कसं ऍक्सेप्ट करावं, रादर आय विल से की म्हणजे ऍक्सेप्ट द ब्लीड और ब्लीड विथ प्राईड हे जे सेंटेन्स आहे हे मॅडम खूप कार्यरत त्या क्षेत्रात आहेत. डॉक्टर गीता बोरा मॅडम, by profession she is ITL, but she did her PhD in computer science. She is a founder of Spiruli Foundation, which works for the woman empowerment, gender equality, sexual harassment at workplace. Her foundation mainly works for the menstrual hygiene, precautions and care. She known as a pad hero of India. took initiative for providing affordable sanitary pads. The real woman empowerment a power from Dr. Geeta Bhogam. I request you to kindly guide us.
Hello, thanks for inviting me. And this is something where I will say what I feel is I'm in between a delicious lunch and so I won't continue for longer. But the thing is, menstrual hygiene thing was known to everyone that India and other countries also facing it. It's not just about India. This problem is everywhere. The only challenge with India or any developing country is it is stopping the progress of girl child. You might not be aware, 1 out of 5 girls drop out from school just when her first period starts. So this is the challenge. The school is giving free uniform, free textbooks, everything. But still, parents are not allowing their girls to go to school. There are other challenges. We don't have proper washrooms. If washroom is there, door is not there. If door is there, water is not there. So there are many things going on. And North India is having a great challenge compared to when we come towards southern part of India. And this journey started when I was in US. I worked for 16 years in US, and then one of my American friend asked me, "Have you visited Taj Mahal?" So this I everywhere tell. Like I've been to India. I've seen so many places. My dad was from army background, so I've been to many states. However, Taj Mahal was something which पता नहीं यहाँ पे कितने लोगों ने देखा है लेकिन it's very if you talk to European or American, they are very fond of it. So I thought, okay, I will go and see Taj Mahal. So I specially booked again a ticket for India, and then I visited Taj Mahal. But it was a destined thing that when I went there, there was a lady guide who was showing me the Taj Mahal, and she was having infections, and I was just talking to her like how you take care of your menstrual flows and all. So she was saying in our village we use cotton cloth, and if you go to our Gujar community or Rajasthan side, even people use ashes. There are girls whom I have found they were using used sanitary napkins. You cannot even believe that how a person can use sanitary napkins, but this is the reality. And we made a short film on that also, and it is also going to come in Cannes festival. So this is a reality where 1 out of 5 girls is dropping out of school. It's still not an open subject, and we are talking about women empowerment. So these are the grassroots issues which we all have to face and we have to solve also. And being a doctor, you all are here. And the thing is, when a person like me who is running an NGO, when it comes from us, it has a different impact. When medical practitioners talk about it, I have many friends who are US based and they have started their own NGO. So when they are working, it has a separate impact. And moreover, when we say, there was a lady who was saying like NGOs are working, still we don't see the impact. There are many things in it. First of all, the NGOs have a limited resource. I'll give an example. During this COVID, we have worked with Honda Cars, Honda Motors, and then Hero, and there are many big foundations and corporations with whom we work. There are specific that we want oxygen concentrators, we want ventilators. We provided in Pune, Delhi, everywhere wherever there was a requirement. Even still, we are importing. However, there is a limited resource, and what we see is the requirement is very huge. Be it is menstrual hygiene, be it is anything, right? So because of this COVID, all started working in COVID situation. Even we started many isolation center across India, and what we found is there is a dearth of medical practitioners in India. And the problem here is another problem is doctors are facing violence because of what I feel when we are on ground. There are many people who are in our isolation center in Haryana. People attacked medical doctors. NGO, what we believe and what we say is lot of what we say academic education, but how to make sure who is the what happens in medical fraternity is always in the receiving end of somebody else's fault. So अगर hospital में कुछ नहीं है तो doctor responsible है. So we have not voted doctor. We have voted political leaders who are responsible for providing good facilities. Governance is there, good hospitals, giving good education system, building good education system, as well as schools, hospitals. So somehow in India, I found citizens are not aware whom to ask questions if something is there, whom to approach. And we really don't understand what governance means. So anybody can easily distract us when election comes. So that should not happen. And NGO's role is like activism is there. But however, this part we are working a lot. And what I feel is our doctors are going through a lot. So I was reading an article where I came to know that is WHO and there is one more organization in US. They said suicidal rate is further, I mean, it's far more than our combat veterans. So why it is happening? Why our doctors are in distress? And there is another thing that we have to make sure that our doctors, we also take care of them, and even our doctors also should, because in there, I think it's always there, they put others first. So they forget ki unki health ka kya. So most of the time, they should also take care of themselves because you are precious, and no NGO, no organization can work. I mean, we have 120 doctors in our NGO, but it's not possible to work without them. We can facilitate, we can provide resources, but other than that, you are our soldiers. So thanks everyone for inviting me here. And I would love to be of any help if you want me anywhere. Thank you.
सामाजिक कार्य तर आपण सगळेच विविध क्षेत्रात करतो. मला वाटतं लेक्चर्स देणे, आरोग्य चेकअप कॅम्प करणे, मेन्स्ट्रुअल सायकल वरती लेक्चर देखील आपण देतो. पण टू प्रोव्हाइड द पॅड, टू गिव्ह द इम्पॉर्टन्स ऑफ द पॅड अँड टू मेंटेन द हायजीन, इट्स रिअली ग्रेट. सो हॅट्स ऑफ टू यू मॅडम. अँड आय एम व्हेरी मच फॉर्च्युनेट दॅट आय एम वर्किंग विथ मॅम अँड पूर्णिमा मॅडम. सो थँक्यू व्हेरी मच वन्स अगेन. मला वाटतं वेळ न घालवता आम्ही आजचे मान्यवर मुंडले सरांना त्यांचं मनोगत व्यक्त करण्याची विनंती करतो.
Hypoglycemia kills faster than the virus. So I will not come between the food and but then I was very happy to be invited in this particular forum. As soon as Dr. Haridas Surane and our office bearers, Dr. Kole and Dr. Madam came up, I said, yes, fine. GP is the backbone of the health system of India, and this fact cannot be denied anywhere. Because as when we saw in the first wave, the participation of GP was not as much as it was the second wave, and the rapidity and the ferocity in which the second wave came, it was only because general practitioners came actively forward, throwing away all inhibitions, and took care of their patients, because ultimately the patients, they believe in the general practitioner. If the doctor has said that that has to be taken and you are there to help you, there was such lot of misinformation about this. Saying of doctor that I am with you helped many people who died over this isolation period and the problems that they were facing. Somebody was there to guide. It was a big lighthouse for all the people around. And that general practitioners have played a great role in treating COVID. Congratulate the GPA for having a new office, and I'm very happy that they have a separate place for themselves to bring up. And I'm sure they will be doing a lot more, and lot many members will increase and take care of the people. Any help anywhere required, any lectures to be given, we are always there. Thank you very much. I will not take much of your time, and thank you very much.
Thank you, sir. Once again, a special thanks to Mule sir and Geeta Bora ma'am. You all made our day. But just a formality to give vote of thanks, I request GPA Secretary Dr. Santosh Ketkar to kindly proceed. प्रसाद सरांच्या आई आणि वडील इथे आलेले आहेत, तर त्यांना बोलण्याची विनंती. President Dr. Shivaji Kolle to felicitate Anvi and Baba. Yeah. Thank you very much. Over to you, Dr. Santosh.
Thank you, Dr. Shubhada. सर्वप्रथम आपण आपल्या सर्व डॉक्टरांचे डॉक्टर दिनानिमित्त हार्दिक अभिनंदन आणि डॉक्टर दिनाच्या आपल्या सर्वांना शुभेच्छा. पुढे जाऊ. संहितेमध्ये दोन श्लोक आहे. तत्वम् अहं कामये राज्यं न स्वर्गप्राप्ति न अपनभवम् कामये दुःखतप्तानां प्राणिनां आत्मनाशनम्. म्हणजे थोडक्यात मला राज्य नको, स्वर्गप्राप्ती नको, पुनर्जन्म नको, फक्त दुःख आणि रोगांनी पिडलेल्या अशा लोकांची मला सेवा करण्यासाठी मी देवाकडे करतो आणि देवाचे आभार मानतो की मला या जन्मात डॉक्टर होऊन काम करण्यास संधी दिली. त्यानंतर आजच्या डॉक्टर दिनाच्या आभार व्यक्त करण्यामध्ये आजचे इमिनंट स्पीकर्स डॉक्टर विष्णू हेगडे सर, डॉक्टर चित्रा सांबरे मॅडम, डॉक्टर सुधीर मुंडले सर, डॉक्टर अमोल देशपांडे या सर्वांनी आपापल्या फील्ड मधील नॉलेज आपल्या सर्वांना अपडेट करून ही सायंटिफिक ट्विस्ट दिली, त्याबद्दल त्या सर्वांचे आभार. तसेच आजचे गेस्ट ऑफ ऑनर डॉक्टर गीता बोरा, चीफ गेस्ट डॉक्टर सुधीर मुंडले यांनी आपल्याला छान मार्गदर्शन केलं, त्यामुळे त्यांचे आभार. तसंच मॅनेजिंग कमिटी मेंबर सायंटिफिक कमिटी चेअरमन डॉक्टर महेश वाळ, डॉक्टर संजय वाळ यांचे आभार. तसेच आजचे गुणवंत विद्यार्थी आणि पालक त्या सर्वांनी उपस्थित राहून सत्काराचा स्वीकार केला, त्यांचं अभिनंदन आणि आभार. महत्वाचे आजचे टुडेज अवॉर्डी जीपी ऑफ द इयर डॉक्टर केनट यांचे अभिनंदन आणि ते सहकुटुंब उपस्थित राहिले, त्यामुळे त्यांचे आभार. खरं तर कुठल्याही अवॉर्डला आपला मुलगा डॉक्टर किंवा इंजिनियर व्हावा असं वाटतं, पण केनट तर दोन्ही झाले. अभिनंदन. तसंच आजच्या फार्मा कंपनी त्यांच्या स्पॉन्सरशिप बद्दल त्यांचे आभार. आता आपण सर्वांनी फोटोसाठी चेअरपर्सन सर्वांचे आभार. त्यांनी फोटोसाठी थांबावे.